Morning,
Morning.
everyone.
Morning.
Hello.
Morning, everybody.
How's Louise? All right?
Yes, I'm fine. Yourself, Paul?
Oh, not too bad, thank you. It's the
Good.
summer, so I think what with the do we change the clocks this weekend? I think.
Is it this weekend? Is it? Oh,
Morning,
that's
Morning.
good news.
everyone.
Morning.
Hello. Good
Morning,
morning.
It's been a year since formally we started the lockdowns of the COVID pandemic, and it's been an extremely difficult year for our communities and for our staff and the organisation as a whole. It's been a year since formally, daily, and started every minute the lockdowns of the tragedies that have occurred, pandemic, and the difficulties encountered by many of our staff and for our communities and for our staff. We wish sincerely, and the organisation as a whole, a real, it's been a year since formally, improvement daily, and started every situation of the tragedies that have occurred, pandemic, and the difficulties encountered by many difficult staff for our communities and for the efforts that they have made in the organisation as a whole. A real, it's been a year to our patients formally, daily, and started every situation of the tragedies that have occurred, pandemic, and the difficulties many difficult staff for our communities and for the efforts that we wish to and the organisation and my independent members for the enormous amount of support and hard work that you've delivered over the last year. Could we have apologies for absence? I have got Angela Mutlow. Emrys will be with us at 12. He has a ministerial meeting, and that is, with your permission, I'd like to move the annual plan till 12 o'clock, because I think it's important that the Chair of Quality and Patient Safety should be with us when we discuss that plan. Are you happy with that?
Yes.
Yeah. Yep. Thank you. Are there any further apologies for absence?
I haven't received any, Chair.
Thank you. Okay. Any declarations of interest in issues being discussed today? No? Okay, can we go then to the draft minutes of the Health Board meeting held on the 27th of January? Are there any suggested amendments?
No.
No? Thank you. Matters arising? Richard?
There were 3 actions, Chair.
Yep.
And I believe all 3 have been actions. Excuse me a second, I have to look at my notes.
There was the annual accounts, and Glinda suggested they complete. Shelley?
Yeah.
Sorry, Chair. In terms of matters arising, I just wondered whether or not the Medipark, on page 3, there was a meeting arranged with Welsh Government officials to progress the development, and I wondered if that had gone ahead and we have any further news on where we were with the business plan and that sort of thing.
Isn't it?
It's Judith here. Shall I come in, Chair?
Yes, please.
Yeah, just to say that meetings have taken place. There have been a further exchange of letters between the Health Board, Torfaen Council and Welsh Government, and we are awaiting a response.
Thank you very much.
Thank you. Anything further? We note that the actions have been taken. Okay. 1.6 report on sealed documents and Chair's actions. Richard?
Yes, Chair. This report provides a compliance and assurance purposes for the Health Board with standing orders. And in this session, we have had 4 documents requiring the Health Board seal. 2 were for the mental health specialist inpatient service, both on the 27th of January, one for a project manager and one for a supply chain partner. And on the 25th of February, there's a form of agreement by deed in terms of appointment of a cost advisor for the same service. And on the 25th of February, the lease for Suite 2 in Raglan House in Cwmbran. And there were 2 Chair's actions during this period as well. One for the additional staffing for the molecular microbiology lab at the Grange University Hospital. This is the CGene equipment. And one for the doctor licence renewal.
Thank you. Are you content to accept those?
Yes.
Oh, thank you. Before we go any further, can I just advise you that I cannot see who is actually going to ask questions, because all I've got are lozenges and then a +6 on the bottom. So if you would like to ask a question, could you just put it in the chat bar, please? Because I might miss you and I don't want to do that. Thank you very much. My report, well, apart from my usual meetings with independent members and executives and the local authority leaders, it seems to have been a very, very busy time. We've had 2 All Wales Chairs meetings where we have been discussing the social care white paper and the new digital health and care Wales programmes. This is a new organisation being set up to take over from NWIS and to extend the programme. And they are getting to grips with a new board and taking the programmes forward, but also enhancing them and developing them further. There has been a lot of discussion with Welsh Government about governance in the NHS, and they have now set up a working group which will take forward the issues that we as chairs have raised. There have been discussions about WISC and the services it provides, and I have invited the chair and the managing director to I think it's May meeting of the health board to give us their annual report and their estimate of their work programme for the next year. We have discussed with HEIW education and training for primary care, and we wait to see the results of those conversations. And of course, we've talked about COVID. I've also chaired a collaborative leadership meeting to look at the work programme going forward and the potential review of the trauma network that was put into place some 12 months ago, and also the establishment of a sexual assault referral centre at Cardiff in the Vale, something that we have been pushing for a very long time, but progress now really does seem to be being made, for which we're very grateful indeed. I've attended RPB, Regional Partnership Board meetings, and we've discussed integrated care funding and the transformation programmes, and we have a further meeting this afternoon. G10, the leaders in Gwent have met, and amongst other things, they were discussing the advantages and disadvantages of a regional public service board, and we await the consultation document which will come to a formal meeting of this board. And I've also attended the new All Wales Talent Board, which is an unusual title for anything, but basically this is about leadership and succession within Wales, to make sure that we are picking up people at an early stage and really developing them well, because as you know, that there is a major concern amongst the chairs and the boards about succession planning, which seems to have been in abeyance for some time, and we really do need to make sure that we can secure our leadership for the future. The Vascular Network Board has also met, and I have to say we have made really good progress. That we are dealing well with the engagement side, and we are meeting with the board of the CHCs, I think it's next week, to discuss progress. This is the engagement is being led by our planner in Aneurin Bevan, and I think that we are well on course for a resolution and an agreement on the way forward for this important development for us and for the whole of South East Wales, and hopefully we'll be able to make much better progress over the next 9 months to enable this to come about, because we have waited a very, very long time for that. Are there any questions? Nope.
Could I ask, is there an update on Velindre because there was something in the paper about the decision being made?
Yes.
And any impact on Aneurin Bevan?
Judith will be able to fill us in on this, or Nicola, but there has been an announcement that Velindre has been approved. The plans for Velindre has been approved this week. Yeah. Well
done. Thank you. Any impact on us with regard?
Well, of course, part of the proposal is for the satellite radiotherapy centre in Neville Hall, which is really excellent news for us. It'd be a fantastic advantage for the populations on the heads of the valleys and for Gwent as a whole. It'd be really, really good. Nicola?
Thanks, Paul. So, yeah, I think it's very helpful in kind of securing the role of the Satellite Radiotherapy Centre as part of the Transforming Cancer Services programme. And it's also really good news for our population who will need to access the Velindre Cancer Centre, as there is obviously still a lot of service provision there for our population. And I think we all agree the current facilities need that replacement, really. So I think it's positive from both perspectives. There is some further discussions ongoing about the right model for acute oncology, but that is happening in partnership across the region.
Thanks, Nicola.
Thank you.
Any further questions? Can we then move on to item 2, COVID-19, and the update, Judith, please?
Yes, thank you, Chair. And just to follow on from some of your opening remarks, I just wanted to say how proud we were as a Health Board to take part in the National Day of Reflection yesterday. We, of course, continue to offer our support to those who've lost loved ones and remember those who sadly lost their lives to COVID-19. And I think yesterday also provided us with the opportunity to reflect on the enormous amount of effort of all our staff have put in over the last year to save lives and care for people affected by this most terrible disease. But I think also to put on record and to add to your thanks, a huge thank you to everybody living in the Health Board area for their cooperation in following the guidelines over the last year, which has, of course, undoubtedly helped to save lives, as well as the enormous gratitude and support that our communities have shown to the NHS staff. So yesterday was a very moving and poignant day, and for all of us really, but we were so glad that we were able to stand alongside the nation and join in that day. In terms of the current situation in relation to COVID-19, I am delighted to say the situation is improving, and the current government restrictions have indeed reduce the incidence of COVID-19 across our communities. Yesterday, we were seeing a Health Board incidence of 41.4 cases per 100,000, which was just slightly below the All Wales average. Across Wales, 7 areas still have rates above 50 per 100,000, and that includes Blaenau, Gwent and Newport. So clearly just to keep an eye on how those rates now are impacted as we slowly open up on some of those restrictions across Wales. Positivity rate is 3.4%, so still relative below 5%, and Sarah Aitken, our Director of Public Health, would say to keep the positivity rate as low as possible, but below 5% is a good place to be. So watching that quite carefully now, but generally positive news for our communities, and again to thank everybody for complying with those restrictions. In relation to our hospital numbers, they have reduced significantly, so we now have 52 positive or suspected patients within our hospital settings and 14 who are recovering from COVID-19. And the non-COVID patients now are 1,397. So we've seen a significant shift now and a rebalancing of our hospital care towards non-COVID treatment and care. And I'll say a little bit more about that in a moment. I know people are often interested in the numbers in how many are in intensive care. So we have 15 patients in total in intensive care as of yesterday. 3 were positive for COVID-19, 2 were awaiting test results, they were new admissions, and 10 were non-COVID. So a vastly improved position in terms of community transmission, but also hospital presentations. Clearly, the vaccination programme is continuing at pace. And again, a huge effort by everybody, not just the NHS staff, but all our partners who come alongside us to help us make our local vaccine programme such a success. I won't go through all the figures because we publish them on a weekly basis, but good uptake and good progress in meeting the requirements. In terms of some and other issues you'll probably be interested in as board members, our sickness levels are continuing to reduce on a slow basis. So our sickness staff absence now is at just over 7%, with 5.2% related to non-COVID related sickness, and the others related to medical exclusion or COVID. So again, an improving position, but of course below that average we still do have departments that have been significantly impacted by the COVID and the pressures. Focusing on the well-being and recovery of our staff is of huge importance to us, and of course staff continue to be very tired and need some time to recover from the last 12 months because they have made phenomenal efforts through the 2 waves of the pandemic to ensure that we are continuing to deliver care to patients. I mentioned that we have significant numbers of non-COVID patients in our hospitals now. Just to say, we are slowly starting to restart elective work. We're doing it step by step, stage by stage, introducing new pathways each week, which is really positive. And of course, and patients now are feeling more confident about coming in for care, for planned surgery, either as the number of rates in the community goes down, or indeed that they've had their own completed their 2 cycles of vaccination. So that's positive. On Monday this week, Welsh Government did publish a paper which was about the restart and recovery of health and care services in Wales. So the executive team will be reviewing that with interest, but there is significant alignment already with the annual plan that you will be hearing about later in the board meeting. So other than that, Anne, nothing more to say. There was also a statement this week on long COVID, and Peter Carr and his team have been doing significant work around the development of our plans to address long COVID. Of course, we are seeing the impact of that in terms of ongoing admissions into hospital and ongoing requests and support needed. So I don't know if Peter wants to add anything to that, but long COVID will be with us significantly for some time to come, and making sure that we're able to reorientate our services to make that offer, which is really important.
Thank you, Peter.
Thank you, Judith. Thank you, Chair. Yeah, absolutely. We are making really good progress in our approach to long COVID, working really closely with Welsh Government, and we've been fortunate to participate in some of the working groups with Welsh Government in terms of the way forward for Aneurin Bevan. We have a executive-led steering group for long COVID, which I chair, and really, really good engagement, multi-professional engagement, multi-agency engagement, but really, really powerful is the engagement from people in our community. And we've made a special effort around that to find out from people in the community what kind of needs they have, to understand this impact of long COVID and really respond to that. And the engagement has been so helpful. Our main emphasis around long COVID is very much about enabling people to help themselves and provide advice and support. But more than anything, I think it's about empathy and showing empathy for people who are really struggling with this, which is a very difficult and unusual disease that's brand new to us, really, as we learn more and more about it. So really positive progress, and I'd be pleased to update the board at a future time on how that's going.
Thank you. Did you want to ask anything else, Paul?
No, I'm really, I think what's been said has been really helpful. I think that it's probably some advice for patients to have some information about it, because I think it is unknown, but also for those who have employment issues in terms of they can't attend work and the impact of long COVID. So some education really about what individuals can do with suffering long COVID, what they need to do, because it is an unknown situation. Also, then what employers need to be advised of in terms of this long COVID, which is an unknown unknown issue, and its impact may be very individualized. But I just think that it's an educational issue. I think that we need to make sure that employers are aware of, and the impact of it on individuals in their workforce, whether or not they can be supportive, etc.
Thank you. Peter, would you like to add to that?
Yeah, thank you, Chair, and thank you, Paul. It is a really important point, and we're about to launch our website for our Aneurin Bevan area, which will have a whole raft of resources to help people in terms of all the various symptoms and experience that people have with long COVID. And I'm really, having looked at the information that we're about to launch, it is really comprehensive and covers a lot of the things that you've described. But also that focus on getting back to work, getting back to normal function is really an important part of that. And it's working with our primary care partners that is essential there, because that's where most of the people who are experiencing symptoms of long COVID are arriving. So it's equipping the primary care workers and workforce and teams to have that information so we can guide people, we can help people, and certainly working with employers to help people back to work. That's what we really want to achieve, really. So yeah, lots happening in that area. So thanks for the question, Paul.
Thank you. Are there any further questions? Okay, shall we move on then to item 3.1, payment rates for funded nursing care. Nick?
Yeah, thank you, Chair. So this is a paper that we normally bring at this time of the year, which sets out proposed methodology for applying a fee uplift for the funded nursing care element of provision in both residential and nursing homes across Gwent. You'll note from the paper that we are proposing to continue to use the IUM, which is the inflationary uplift mechanism, which has been set out since 2014. The difference this year compared to last year is that there was a proposal that during the year 2019-20 we would be conducting a review of the approach and the uplift mechanism, but because of the COVID situation, then unfortunately that review of policy and approach has not taken place. So in order to put in place a mechanism for this year, the paper proposes that we continue to use the IUM to guide FNC rates for the coming year, with the clear and stated objective that the National Commissioning Board and others will review the situation through the coming year, so that we do not face the situation where we're in effect rolling over the methodology for a further year. It's unfortunate that we've got to that point, but I think it's clear that the mechanism that was set out in this paper is one that is well considered and has been supported by all of the health boards and has been considered by the National Commissioning Board as a recommendation, has come through to both the lead directors for this service across Wales and also the Chief Executive Group, and comes here as a recommendation that we adopt and extend that mechanism for a further year. We've sought, and the group has sought, different views from other parties across Wales to this approach, and we've had, I suppose, good response from the health boards, but little response from elsewhere. But it is, I suppose, a tried and tested mechanism, which has not been subject to further challenge since it was put in place in 2014. So the paper recommends that we adopt this approach, and obviously note the recommendations from the other professional bodies and the Chief Executive Group to adopt this and move this forward, hopefully at pace in the coming 12 months with a review that we would then bring back to the board at this time next year. So I wasn't going to go through the paper in any further detail. I'm happy to take any questions, but this is obviously a similar proposal that we've had in previous years at this meeting at this time of the year.
Thank you, Nick. Chris?
Yeah, thank you, Nick. Thank you, Chair. Yeah, obviously this is rolling over existing arrangements, but I just wondered, in view of the backdrop of the last 12 months, and I see from the paper that we haven't had any formal feedback from providers, but what's our view on the possible impact on our local providers of this? Is it going to have any negative impact, do you think?
I think I think, Chris, it's difficult to assess the impacts currently. So obviously there's quite a considerable amount of financial support that has been put in place to support placements both in residential and nursing homes over the last sort of 6 to 12 months. That support has been extended, I believe, for a further 6 months, certainly a minimum of 3. And during that period of time, I think we need to assess the sustainability of the sector and the way in which the service moves forward, because it is very unclear at this point in time of the sustainability challenges of particular homes. In terms of the uplift as proposed, I mean, it is in line with, you know, their expectations. So I don't think from an FNC uplift perspective on its own it is a particular problem for providers. I think the bigger issue as we move forward is the demand and capacity scenario within the sector, and I think we need to try and work out what the level of demand for FNC placements and other services will be over the next few months, so that we can put in place policies and practices that support the market as we would seek to support it for the next 12 months, 2 years, because I think it's going to take us that long to really understand exactly what is going on with the market and the type of market that we require as we move forward.
Okay, thanks, Nick. And presumably there's a read across here to the white paper proposals.
Indeed, yeah. Indeed, I mean, obviously we're going to have a discussion about that later on, and I think there's something about within the white paper around obviously regional commissioning and how we commission on a whole Gwent footprint that again is about commissioning for quality and also the right level of procurement of particular services. We just talked about long COVID and how do we provide placements and other services for reablement and rehab in this sector is going to be quite key as well, I think.
Okay, thank you, Nick.
Thank you. Emrys?
Hi, Nick. Two questions for me, Nick. The first one is that do we know how long the Welsh Government review will take? And you may not be able to answer that, but I suppose the big issue for us then is the potential implications as a consequence of not having that review completed.
So I think the consequences are obviously borne out this year in terms of the fact that we are rolling over for a further year a mechanism that should have ended in March of this year. The National Commissioning Board and National Group have been very clear that they want to complete the review and establish a new mechanism in the coming financial year. So that's their intent. The implications of a further rollover, I'm unsure of at this point, Emrys, if I'm honest.
Okay, and thanks for that, Nick. My second question would be is that obviously care arrangements compose of both social care and healthcare costs. And I noticed that local authorities haven't contributed to as part of the when you're considering this proposal. Do we have any views as to why that might be?
I think what's quite clear is that health boards, from an FNC perspective, when we commission care and pay for care, we establish a framework, and we all, as 7 health boards, tend to stick to that framework and the methodologies. Whereas I think there's a much more local flavour to the way in which local authorities act, both in setting their fees and also in terms of commissioning care, and that can vary. In our area by 5 different local authorities. So there doesn't seem to be a single approach, is probably why they haven't therefore committed or commented on the approach being adopted by health in this matter.
Okay, thank you.
Thank you. Thank you, Emrys. Phil?
Sorry, yeah, just going to say, Anne, that our biggest problem with this whole market, which I'm sure we'll touch on this afternoon, is that we don't commission actually care. What we do is that we buy beds in the sector. So what we need to look at is a whole new methodology, the way our whole relationship with the independent sector should be a commissioning one. where we engage them in exactly what it is that we're going to need now and maybe over the next 25 years, and then we actually commission properly for that kind of service. And of course, it's one of the failings really of the way the Regional Partnership Board has operated over the last 5 years, is that we've not been able to do that, and that's one of the reasons that we now have a new white paper from government. But I guess this is one of the central problems that we have, and Nick has handled it beautifully there when he's talked about, and your question about the issue of no response from local government is because that's one of our big problems, is we struggle to get a collegiate response from local government to many of these big issues. I'm sure we'll touch on that later today. Thanks, Anne.
Thank you, Phil.
And Phil, just to pick up on the point that you put in the sidebar around that we have budgeted for this, so the estimated cost is around £72,000, which is in the budget for the coming year.
Could I just ask Nick, is there a likelihood that the providers will come back to us? Because this seems to be an uplift based on inflation. Are there any other issues that we should be considering, which should be included in any uplift because of the extraordinary circumstances in which we find ourselves?
So I think, Anne, that's probably been dealt with within both the hardship fund and also the mechanisms that have been put in place with regards to vacancies and voids within homes, and the payment mechanisms that have been delivered, if you like, over the last 12 months and will be extended into the next 6 months. So I think the question is valid, I think, post the removal of support funding and what that means as we move forward.
Thank you. Thank you very much. Any further questions on this? Okay, keep our eye then. Could we go on to 3.2, Refit Cymru Energy Performance Framework, please? Nicola, are you starting this off?
No, it's me, Anne. It's Claire.
Oh, Claire. Sorry, Claire.
Hi. I'm sorry, I am intermittently losing Wi-Fi, so I do hope that this stays for this item. So, Borodol, thank you, Chair, for allowing us the opportunity to present this paper today. Matthew Lane is also on the call with me. He's our Energy and Carbon Manager, and you will remember Matthew from when we've previously presented the Estates Energy Strategy. The presentation of that strategy outlined our commitment and progress towards the NHS Wales Decarbonisation Strategic Delivery Plan. And this presentation today really asks for the support to invest in a framework that will allow us to continue to deliver on that ambition. The framework has been used in NHS England very successfully and is started to be used in other Welsh health boards. And we would very much like to take this opportunity to invest and allow us to deliver on our ambition and some of the challenging targets that we have ahead. So I'll hand over to Matthew to go into the detail of the report and allow any questions, and then we'll just sum up in terms of the what we're asking the board to support us with today.
Thank you. Welcome, Matthew.
Okay, good morning, everyone.
Good morning.
Thank you for the opportunity for presenting the report this morning. Hopefully the sound and the comms are working. So you will have had the time to digest the report and the recommendation that we're seeking approval for today. So I should just run through an overview of the paper and the approval being requested. So the Refit Cymru programme will offer the Health Board the added capacity and capability to accelerate its carbon reduction activities at scale and at pace. The Refit Cymru framework offers a contractual and procurement mechanism with the benefit of savings being guaranteed by the service provider. As a background, the role of the Refit programme will allow the Health Board to progress with our ambitions set out in our energy strategy, our estate strategy, and our obligations set out under our wellbeing objectives. In addition, as Claire mentioned, the soon-to-be published NHS Wales Decarbonisation Strategic Delivery Plan sets out ambitious carbon reduction objectives, and aligning our actions through Refit, similar to other Welsh health boards, will allow us to make significant progress and realise substantial carbon reductions. So, Following on from the endorsement from the executive team, this report requests final approval to proceed and to sign up with the REFIT programme. The programme will allow us to utilise energy performance contracts and a guaranteed savings mechanism. REFIT will provide the contractual and procurement framework to allow us significant investment in energy efficiency and renewable technologies. In terms of finance and funding, we have the option to bid for capital or to use the Welsh Government's Invest to Save scheme through the Wales funding programme. Both schemes are, of course, endorsed by the Welsh Government. Energy costs for the Health Board, as we are aware, are very significant, totaling nearly £7 million last year. And through our activities running our hospitals and other clinical services, we emitted nearly 22,000 tonnes of carbon. We'll be analysing this year's performance in terms of pounds per metre squared and consumption per metre squared, and report it through, as we do every year, through the sustainability section of our annual report. In addition, we'll be conducting analysis of performance of the GUH to draw a comparison with its design specification and its current operating energy use. A brief sidetrack on that one is that year to date, GUH is performing slightly worse than its design, but normally that is very expected in the first year while we commission and continue to commission. Only maybe 10% outside of its design parameters, so it is still doing what it should. In terms of policy and governance, the Health Board is committed to an annual 3% reduction in CO2, and the Welsh Government has also published ambitions to be carbon neutral by 2030. REFIT offers us the ideal framework to build upon previous carbon reduction success, but now is a pertinent time to do more. Both the NHS Wales Decarbonisation Strategic Plan and the 10-year estate strategy prescribe a challenging pathway for tackling the climate change agenda. Decarbonisation activity in a scaled programme such as REFIT is therefore needed now to enact transformative change. With the changing nature of our estate and working patterns as we emerge, hopefully, into a post-COVID world, we'll be able to target and prioritise what we do, where, and how and where to improve clinical environments most effectively. Supporting us through the REFIT programme will be the Welsh Government Energy Service and local partnerships who will provide contractual, technical and procurement support. From previous surveys and audits, we've identified a scale of opportunity to the value of nearly £7 million. Typically, with those projects identified less than an 8-year payback. It will also complement the current bid that we put into Welsh Government under the decarbonisation agenda. Projects across our main hospital sites and small clinic sites will all be considered. Through REFIT, we will partner with one of 16 service providers on that framework to undertake feasibility and installation of a suite of low carbon or renewable projects. Things like LED lighting, improving our building management systems, solar panels, heat pumps, adding insulation to our buildings. We will of course consider cost and effectiveness for cost and carbon, plus also where plans for our estate will be incorporated into our decision making around investment. We envisage a structured programme of investment over several work phases over the forthcoming years, also by utilising local companies where we can to reduce that overall carbon footprint further. We anticipate to realise savings typically, as we've seen with other health boards, around the 20% mark. Over time, we could potentially realise a saving in the region of around £800,000 annually, based on our current footprint, and our CO2 savings could be as much as 16%. In terms of delivery options for this, a do-nothing approach is not really viable. We would fail to meet our legislative requirements under the Environment Wales Act 2016 and also the Wellbeing Act 2015. Also, we would fail our obligations and objectives set out in our strategies and other national plans. The preferred option, therefore, is to proceed with the refit programme and to have the added benefits of the savings guaranteed to us by the service provider. The refit programme will provide a delivery route with a service provider to take on the role of designer, main contractor and project manager, who would scope, design and project manage the installations with us overseeing. Along with project management support from the Welsh Government Energy Service and local partnerships, a coordinated and structured programme can be developed for securing long-term investment in decarbonisation of our estate. We have two funding options available, as I mentioned, to utilise our own capital or to utilise the Welsh Government's Investor Save scheme, or a blended option of both to allow more flexibility. We've identified key individuals across the organisation that will assist us as key stakeholders in shared services, legal, finance colleagues, and of course other colleagues in estates and facilities. In terms of the next steps, we anticipate spring covering off contractual elements and a summer leading to an appointment of a provider, with works commencing hopefully early autumn. So, in conclusion, by approving the recommendation to proceed with the refit Cymru Wales programme, the Health Board will be able to accelerate its decarbonisation ambitions. Refit will offer us a structured framework contractually and in terms of procurement, the guaranteed savings element offering us a no-risk approach. It also covers the 5 ways of working under the Wellbeing of Generations Act as well. So the recommendation to the board is therefore 1, to approval to proceed with the Refit Wales programme, and 2, approval of the proposed funding options open to us. Funding will therefore be secured through capital bids or Welsh Government Investor Save, or indeed where appropriate, a blend of both, but also recognising that should other forms of funding become available for other schemes, that we will consider all options. Thank you for your time.
Thank you, Matthew. That was very clear and helpful. I've got Paul, Chris, Shelley and Tej. Paul?
Yeah, just to say, I mean, huge thanks for this report, Nicola, and particularly Matthew for its presentation. I mean, I think what's been helpful has been there's been an options appraisal, which you've considered, and I think actually and I'm fully supportive of the preferred option model, because I think that is incredibly helpful, because ultimately there will be a reduction in carbon footprint and there will be savings made, and not only that, but there'll be regular reporting to the board. So I totally endorse what is proposed, and I thank all that have been involved for doing it, because I think we do, with the Future Generations Act, we do need to be thinking about our future and how we can help reduce the carbon footprint, and this is just one example of an organisation sort of moving forward on that agenda. So I fully support what's proposed.
Thank you. Chris?
Thank you, Paul.
Yeah, thank you, Chair. I've had the opportunity to discuss this report with Matthew and Claire earlier in the week, and I, like Paul, I think it's an excellent way forward. I did have a couple of questions, though, which are probably a bit peripheral to the report in question, but something that the board needs to think about. One is, as I wondered, and I raised the question earlier in the week about what the impact of agile working has on the way in which we approach our carbon reduction. So that was the question, and probably something we need to come back to. But one of the implications of agile working, new ways of working, people working from home, is that we might see a reduction in our own carbon footprint, but we could be seen to be transferring it to our staff who might be working from their own homes. So I was just suggesting that we come back to that and just think about what we can do to support staff in managing their own carbon footprints as part of the agile working approach. But like I say, I think it's an excellent way forward and a way of, at fairly low risk, reducing our carbon emissions and also making financial saving.
Thank you, Chris. I think that's a very sensible suggestion, and we would endorse it. So we'll bear that in mind, please, and come back to it. Shelley?
Yes, Anne, I also had the opportunity of speaking to Claire and Matthew earlier in the week, and I absolutely support this report. I think it's fantastic. And one of the things I was wondered whether or not it would benefit the board to have a development session on decarbonisation requirements that are set out by Welsh Government, because I know as a board we will have those responsibilities. And I think perhaps some of this is quite new to certainly to me, and I know that there are some training opportunities available on carbon literacy, which I think would help us perhaps understand our responsibilities better. I know that Matthew will have been on a training course with that, and I just wondered whether or not he could perhaps, or colleagues could, develop something that would be suitable for the board, just to make sure that we understand what we're supposed to be agreeing to and what progress we're being made. Thank you.
Thank you, Shelley. It was a very sensible suggestion, and unless anybody has any alternative views, then I think we'll proceed with that suggestion, please. Thank you. Tej?
Thank you, Chair. Like the others, I very much support this. I think it's excellent, and the information that's been provided has been very helpful. Thank you. Just a question, and I'm assuming that this is the case, but I will ask it anyway, that within this and the contracts that we will be awarding, that there is a strong element of use of local labour force, because clearly we want to employ labour as local to home as possible to contribute to reduction in carbon for a start, people travelling, and also we know that good jobs means good income, which means good health. And that is something that we would like to support. So my question is, can we just be assured that that is that we are paying mind to that? And secondly, when you come back and report, could we have a little bit of information on that, please?
Yeah, Matthew and I had this conversation yesterday, actually, Katia, and we think that we will have the opportunity to maybe outline some of those key things when we have these conversations with the local partnership, with the local partners arrangement within the framework. So Matt was going to go away and specifically take a look at that and whether there's any learning from other health boards. So thanks to each of that.
Sorry, could I just also add, where there is any opportunity to support apprenticeships as well, our commitments within all of the public service boards, for example, is around really trying to support education and bringing people through, again, good jobs, good income and good health. Thank you.
Thank you. Are there any further questions? Well, thank you very much indeed for this report and the work that's underpinned it. Are we happy to approve the recommendations and approve the investment required through the methodologies that are outlined in the report?
Yes.
Yes.
Yep. And thank you very much, Claire.
Thank you.
Claire.
Thanks, Matt.
Thank you.
Thank you, everyone.
Could we move now to the capital programme, please, Nicola?
Yeah, thank you, Chair. Can I just check the sound is okay?
You're a bit faint, which isn't like you.
I know, I think my sound is not great on my laptop, so I'll speak up.
Better.
So the paper reports on the proposed opening capital programme, which we usually bring to the board in March of every year, ahead of the new financial year. So this paper is seeking board approval to the opening capital programme for 21-22, and also recognising award of funding potentially from Welsh Government for targeted improvement funding, and the Imaging National Programme, which I'll pick up through the report as well. So as most of you will be aware, the capital programme is made up of two components: funding we get through All Wales capital funded projects and the discretionary capital programme as well. So before I go into 21-22, I thought I'd give a brief update on where we are with 2021, which we've got, I think, is 7 days left, isn't it, till the end of the financial year. And it's been a pretty challenging year from a capital perspective, not just because we obviously had the final, more or less the last phases of the Grange project and then an early opening, but also all of the funding associated with COVID in amongst that as well, and has resulted in a number of changes to the capital programme and has required us to be much more dynamic and flexible and required very close monitoring. And I can't thank Kelly Jones in finance enough and Mike Ellery in terms of their continued hard work in managing this programme. Appendix 3 to the report had set out the latest forecast against the opening programme, and we are on course now to close that down at the end of the month, and Glyn will give a final position in his finance report at the May board. There is quite a significant amount of brokerage between Will's Capital and discretionary, which I'll pick up in a second under 21-22. But I also made reference in the report to a potential change that could have happened, which was in progress at the time of doing the board report, around securing the licences for the Lightfoot SFN model that was a key linchpin for the development of the Clinical Futures programme and the opening of the Grange. And we have now approved that through the executive team. It's had chair's action and is currently with Welsh Government awaiting ministerial approval due to the procurement value. Assuming that gets approved, that will be an additional 1.4 million that will be included in the capital programme this year. That is being managed due to a number of equipment items that were going to be required to be vested because of delivery challenges. And therefore, we will release the vesting of equipment and will include this licenses, which is a much lower risk solution as well. So the plan is, I've been in discussions with Welsh Government to try to get this funding back next year as part of the Grange slippage, and I will progress with that proposal in the new financial year, which will recover this back into our discretionary programme next year. So in terms of 21-22, the current opening position was £19.5 million between discretionary and All Wales Capital. As I just briefly mentioned, in November, and this is a new approach the Welsh Government have taken in the last couple of years, is we then get our capital resource limit fixed, and any slippage from November on is required for us to manage between All Wales Capital and discretionary, or we have to hand the money back and lose the funding. So due to some slippage primarily on the Grange Hospital scheme, and this is primarily due to some IT funding which we need to carry forward into next year, and some further slippage that we've seen on equipment due to procurement savings, we have now got 2.6 million we are carrying forward into next year. I think it's worth just highlighting that there will be 4.9 million available next year for the Grange. There are some, as I mentioned, IT and mobile telephony work that's still to be completed. There's still some decommissioning budgets for the ELGHs, and some of the arts strategy funding is still outstanding. But we are in discussion with Welsh Government to utilise some of this slippage on the Wellbeing Centre of Excellence that we are proposing in Alders House on the Grange, on the Llanrechford Grange site. And again, also to be able to use some of this to secure the Lightfoot tool, which again is very much linked to the Grange project. I think it's just important to note that, you know, in terms of the overall budget, to end up with a continued underspend on this project in the context of the scale of the challenge, we have managed to address a number of issues that have come up since the move, whether that's new pathways across the hospital, additional car parking, doctors' rest facilities, anything that was potentially coming up from feedback from the public or our staff, we have managed to put right, and have still managed to maintain this position on the budget. And that's in addition to funding that we've returned to Welsh Government as part of the gain share arrangements. So I think it is worth noting that, you know, we have delivered the £360 million scheme with quite a large underspend, well, not a large, but, you know, an underspend that we are hoping now to focus on our well-being for our staff in particular. So what we have done in order to manage that, we've just brought forward a number of schemes that were in next year's discretionary programme into this year. So we've managed to get quite a lot of equipment into this year earlier, which has obviously helped the services as well. So if I just concentrate on the All Wales Capital funding for next year, you'll see that I mentioned the Grange. We've also got 1.2 million approved for Tredegar, and you should have seen the communications last week where we've now had formal approval from Welsh Government for the Tredegar full business case, which means we are now heading into the construction phase, which is really good news for this development. The radiotherapy satellite centre, as I mentioned last meeting, we had the outline business case approved, and therefore we now move into full business case stage. The mental health specialist inpatient unit, we are now progressing with the outline business case. The HSTU at Llanfechfan alongside the Grange, that is due to be completed in July of this year. The breast unit, we are hoping the full business case will come to the board either April or May, so that we can seek approval for that to progress to construction, which is again another important development for us. And the last item, there was some slippage around one of the ICF schemes around a rebound facility at Sireni. They were the main All Wales capital programmes, so we've either got funding for or in progress. And there's a number of other schemes mentioned on the bottom of page 5 where they are emerging projects that we're in discussion with Welsh Government where we will be seeking All Wales capital funding. They relate to a new endoscopy unit at the Royal Gwent, some early planning around a new front door, kind of a new emergency department or minor injuries alongside the assessment unit to be better located at Neville Hall. The cancer unit that's going to sit alongside the satellite radiotherapy unit at Neville Hall. And then there's a whole range of local general hospital infrastructure projects, particularly at the Royal Gwent, aligned to the reconfiguration of St Willow's Hospital. So all of those are kind of in development, and we'll have ongoing discussions with Welsh Government. And once we understand the scale and the value of the potential project, will help direct us down which path we will need to go, as whether it's the business justification case, full outline business case, or so. So that's the All Wales Capital Programme. On the top of page 6, Welsh Government have also put 36.5 million aside for next year for what they've called estates targeted improvement funding. This was to target a number of key areas where they felt we needed to put some additional funding to support and complement local health boards' discretionary programmes. So you'll see that we have pulled together a number of bids across the different headings, which include mental health and learning disabilities, infrastructure, fire and decarbonisation. So we submitted bids to the value of 9.4 million, and there is an overlap on the decarbonisation with what we just discussed with Claire and Matthew on the refit programme. Anything we could deliver in next financial year, we included in this submission, because the one criteria of the bids was 12 months only, so you had to pick the schemes that you knew you could deliver in year. Of the 9.4 that we've submitted, we've had notification that 5.4 of those have been put forward for ministerial approval, which we are waiting the decision on, which would be really good news and an additional funding source on top of our discretionary and All Wales capital. So you can see there's a detailed breakdown in one of the dependencies as well. There's also 25 million set aside for digital, which is still not quite finalised, but has made good progress. So we are hoping we will secure some of that funding to support our informatics agenda. And there's also the Imaging National Programme, and I've set it at the bottom of page 6, CT scanner and 2 X-ray room upgrades that are priorities for the health board as part of the National Diagnostic Programme. So moving on to the discretionary capital programme. So our opening programme of 10.8 is now reduced by 2.6 as a result of the All Wales capital brokerage I just described. And we're also anticipating 1.1 million additional capital for disposal of properties. These are quite well progressed. We are hoping we will have that funding in place by the end of Q1. As we have already been through some of the market process and auctions. So we're in a pretty good position around that. So that'll give us £9.3 million discretionary funding to start with at 21-22. And you can see that that's then been allocated to commitments brought forward from this year of 3.2 million. The two big components of that is just under 800,000 for the ward replacement programme at Neville Hall, which we delayed due to COVID and the need for us to have that capacity available. So that's phase 2 of that ward refurbishment. And then there's just over £1 million for the third phase of the lift replacement programme as well of year 3. That was a £4 million scheme in total. The statutory allocations are fairly standard and also include some asbestos removal And then there's 2.2 for divisional priorities. And we go through a very detailed prioritisation process with divisions to identify where their highest risks. Some of the discussions we've had is that the mental health share of that allocation is smaller than normal due to the All Wales mental health funding, but we have agreed as part of the programme group is that we will prioritise mental health if we have any slippage or further the use of contingency, because we do recognise some of the scale of the mental health estate in particular. And there's 2.2 set aside for informatics, and again that will be revised and refreshed once we understand the national digital picture. It leaves a sum of 900,000 as a contingency, which is fairly standard practice for our capital programme planning. So we've got a number of schemes then that are sitting below the line, which, as we said, is the next set of divisional priorities or emerging projects, and again particularly around the ELGHs and any schemes that will come up during the year that are currently in progress. So I just wanted, recognising there's a lot of detail in there, but they were the key headlines. So I just wanted the board to approve the opening capital programme, recognising it is a dynamic process and things will change. Approve the bids that we've put forward to Welsh Government, that we're awaiting approval for the estate's targeted improvement funds, and also the Imaging National Programme bids, and particularly pay note to any of those that are over £500,000 in line with our approval processes. So that's all I wanted to say. Thanks, Chair.
Thank you very much, Nicola. Paul?
Can I just check, Nicola, you didn't mention Newport. It's on the recommendations. I just want to check with you or confirm with you that the Newport Centre is one of those.
Oh yes, apologies. Yeah, it's that's obviously at the full business case is progressing, so all is in hand with that as well.
Well, all I want to say, Anne, was I think we've got a considerable range of opportunities with regard to development and capital programme, and look at the acute services, primary services, community mental health, learning disabilities, and equipment and projects and radiotherapy. I mean, it's a considerable investment in services for the future, and I fully support and endorse what's proposed.
Thank you. Chris?
Thank you, Chair. Thank you, Nicola. Like Paul, I think it's a well thought out programme. I just had a couple of points. You mentioned there's obviously in all capital programme planning, there are more bids than resources. And you mentioned both in the report and your presentation about taking advantage of any slippage elsewhere. How do we ensure that we're able to do that? That was my first question. And the second one, we also, if I'm reading the report right, we're expecting over £1 million of capital income to help support this. How secure is that in being achieved to help us deliver this programme?
Yes, the £1 million relates to 2 of the learning disabilities properties. They've progressed quite well through the sales mechanism. They've been to auction, a number of bidders. There's been successful bids accepted. So we're just now through the legal process. So we are hoping they'll be secured in the first quarter of the new year. So give us that certainty. We obviously won't release or commit spend to that value until we've got that confidence that the funding is in. In terms of this first point around in terms of managing slippage and making sure we optimise the capital programme, often when we get slippage late in the year, we'd often then have to prioritise based on what can be delivered, then perhaps what is the top priority. So what we have done as part of the programme is a good example is there was about £500,000 worth of ultrasound equipment that is due for replacement in March 22. So we've kept those out of the programme because I don't think I've been through a capital programme yet where there's no end of year either funding from ourselves or Welsh Government that would very much suit that equipment, at short notice. If not, we can also use our discretionary programme on the 1st of April next year. So where we've got areas such as that, we've put those aside as part of our contingency list and prioritise the schemes that need that longer lead time and the longer planning. So I think there's sufficient schemes that sit at the there's a long list by each division, as you can imagine, that I think our first draft came to 15 million and we had to get it down to 9.3. So we've got all of those in priority order with divisions and facilities and estates, so that we know which ones we would bring forward, because they're all risk scored. So we then move to the next level of risk scoring groups, and again, what's deliverable in the time.
Thank you, Nicola. Pippa has a comment. Do you want to outline your comment, Pippa?
Yes, I just wondered if it was possible for us to perhaps think about having a board briefing on how we managed to tie together the capital expenditure, the refit for Cymru carbon footprint that we're looking at, and how we can tie all of this together under the estate strategy, so that the board has got a really clear kind of overall picture of what our estate is, what it does, how much carbon it's producing, how we want to develop it in the future, so that we look at it in a kind of much more holistic and long-term way. So I just wondered if it was possible to have a board briefing or something like that in the future.
Well, we could take this into the planning and strategic change agenda, couldn't we, and have a session on that?
Yeah, and I think we did have one early last year as well, so we would fit with an annual review of how we do it on the strategy. We've also just finalised the latest capital matrix, which is a 10-year outlook of what for the schemes we know are already in place or are in progress, the areas that I suggested as emerging projects, and then a whole range of other areas where we anticipate we will need investment over the next 10 years. And we've submitted that. I think we discussed that previously at the planning committee, just so that we've got that 10-year outlook as to what our capital requirements are. But yeah, I think I'm happy to have that session on the estate strategy, and alongside the decarbonisation one, I think is very helpful.
Great, thank you.
Thank you. Are there any further comments?
Well done.
I just have two. Firstly, I think I would completely endorse your proposal that any slippage is spent in the mental health field. I think that's a good idea. And the second one is a question, really, because and that's about the National Informatics Programme and the 25 million. Have we had a clear indication that this is going to be allocated between health boards, or is it all going to go to Digital Health and Care Wales?
No, it's a combination. It is based on national digital priorities. There was a session in the middle of February with Health Board and Trust leads alongside NWIS and Welsh Government to look at those digital priorities, many of which were already in place pre-COVID. And I know a lot of the budget was redirected during COVID to support the priorities, to support the pandemic. So that's kind of come back onto the table now. So some of these will be to address core infrastructure nationally, in terms of data centres and so on. And then some of it will support programmes such as technology enabled care or the WCCS programme. So it's made up of a combination of different components. So some of which will sit nationally and some of which will find its way to local health boards and trusts.
Thank you, Nicola. That was very helpful. Are there any further questions or comments? If not, are you happy to approve this capital programme? And we'll look forward to additional reports on it and further progress. A huge amount of money being spent locally to improve the facilities we have available to the communities, which is really, really good. So thank you very much for that. Might we go on then, dropping past 3.4, the annual plan, into the delegation of revenue budgets, please. Glyn.
Thank you, Chair. Thank you. And originally I was sort of planning to talk through this paper on the back of having approved the annual plan, but we'll try and sort of manage it the other way around. So I'll make references to the annual plan because obviously this is entirely relevant to how we deliver the annual plan in terms of allocating budgets. Sorry, there's a little bit of feedback noise.
Yeah.
I don't know if other people can hear that.
Could people mute themselves if they're not contributing? Thanks ever so much. He's having a gossip somewhere.
That's better.
Thank you.
Thank you, Chair. Thank you.
Thank you.
So as a board, you'll probably be aware that we're required to set revenue budgets prior to the start of the financial year. And this paper is really set against the backdrop of uncertainty that we face as we go into next year. A little bit like this year, it's not a normal year. We will still be responding to COVID, and we'll also be looking at how we recover from the pandemic as well. So it's made it quite complicated, if you like, in terms of understanding what level of funding we're likely to receive next year, our ability to deliver savings, but also our spending plans in some areas. And so that backdrop is quite important to understand in terms of how we've approached the way that we've set the budgets for this year. And the approach that I've very much taken in the paper is to look at three different parts of the financial plan. One is around, so what does our normal core financial plan look like if we didn't have COVID? What would our services look like? What would the workforce look like? And therefore, what are the financial resources that we would need to go alongside that? The second bit then looks at what do we think COVID response looks like during next year. So in what way are we having to deliver services in response to COVID, and we'll touch on some of those, and therefore what is the workforce required and the financial resources. And then the third part is around COVID recovery, and as Judith mentioned earlier, there was an announcement by Welsh Government at the beginning of this week setting out a recovery approach and announcing £100 million of funding. Now at this stage we don't have any more detail around that, but clearly there will need to be a level of recovery taking place as we go through next year. So I've deliberately tried to structure the plan and the budget setting in those three broad areas, and at this stage the budget setting paper doesn't make any assumptions about recovery plans or recovery funding. And that's something that we will need to come on to as we go through probably the first quarter of this year. So the core funding that we've had for next year has been quite simple in some respects, in that we've effectively had a 2% uplift to cover the cost of inflation, and an assumption at this stage that there would be a 1% pay award next year. Now, that of course may all change, but at the moment that is the current financial planning assumption that Welsh Government and ourselves are making. And we've therefore used that to reflect the budgets that we're looking to set for next year. What I've then also included in the budget setting paper is what I think are reasonable assumptions around spending plans for what I would term COVID response. So these are things like maintaining some of our surge capacity, maintaining COVID pathways in our hospitals. So even though the number of patients is rapidly falling within our hospitals, we are still caring for COVID patients, and will continue to do so as we go through certainly the early part of next year. We're also providing things like contact tracing, testing and mass vaccination programs. So again, I've made assumptions about what we would need to spend, and also made assumptions about reasonable funding that we can build in to our budget settings, so that people who are managing these budgets have got a realistic budget to manage for next year. Now, some of this information is beginning to emerge from Welsh Government in terms of funding for next year. They very helpfully confirmed funding for contact tracing next year. So we know that for the first 6 months of next year, we will have funding of £9.2 million to fund the contact tracing service that we deliver in partnership with our local authorities. We've also been made aware of the likely funding that we will get in terms of COVID response next year. Now, some of you may have seen the announcement that was made towards the end of February by Welsh Government around the budget for next year, the Welsh Government budget for next year, which included an extra £380 million for COVID to cover the first 6 months of next year. And again, helpfully, we've had an indication of the level of funding that we're likely to receive linked to COVID response. Some of that will be based on funding national programmes. So where we've identified programmes to deliver things like mass vaccination, where we're looking at things like testing services, that will be funded through a national programme overseen by Welsh Government. There will be other things that we will deliver through our local plan, and some of this is contained in the annual plan around COVID response, and we will receive our sort of formula or funding share of about £170 million to cover the first 6 months of next year. That translates to about £32 million for us as a health board. So the picture is becoming a little bit clearer in terms of financial assumptions, and that means that with a reasonable level of certainty, I've assumed some additional funding in setting the budget for Q1. So the paper, and I won't go through this in detail, the paper sets out a range of assumptions around levels of funding that we're expecting. It also looks at savings and efficiencies, and this is really important not only for this year, but I think as we look recurrently around our position, and as we move out of COVID into recovery and what we would regard as being a more sustainable position. And it's important to note that at this stage, we would be required to deliver quite significant savings, particularly recurrently, in order to fund a number of the investments that we've made around things like our hospital network. So opening of the Grange Hospital, the ELGHs that we have in place, we need to deliver savings to make that financially sustainable going forwards. At this stage, I would say we've probably identified savings of about £8.5 million next year that I would be confident we can deliver at this point in time. There is probably about another £5.5 to £6 million of savings that I think during the course of the year we should be able to develop plans and implement, and therefore deliver further savings through the year. In terms of making further savings, well, this links back to the annual plan that we're going to discuss later, and our approach to looking at pathways of care and redesigning those pathways of care based on understanding how we can improve outcomes for our population, but also understanding how we can realign some of those financial resources to make better use of them. And this becomes quite complex then in terms of describing those either as savings or potentially just realigning resources to address some of the investments that we've made over the years. What you'll also see, and it's in the finance report that I'll come on to later, is this year, because we suspended a lot of elective care services, we've actually avoided spending around about £40 million related to those services. So as we start to resume some of those services, the work that we do around pathway redesign, the way in which we approach the resumption of some of those services enables us to make a choice about to what extent we commit some of those financial resources going forward. So this is why it's quite uncertain, and it's quite an unusual year in that we actually have some of those choices that we can make. And it's really, really important that when we consider the annual plan later, and there are 5 very clear priorities at the end of the annual plan, that we actually make progress on implementing some of those changes in pathways. So one of the priorities, for instance, is around redesigning our MSK and eye care pathways, continuing the transformation around outpatient care. Those are the areas that we really need to make progress on during the course of next year to not only improve outcomes for patients, to address some of the high risk areas around harm to patients, but also enable us to realign some of our resources. And it's really because of that level of uncertainty that I've proposed in the paper that we set a budget for Q1 based on what we know at the moment. But then as we go through Q1, I'm hopeful that some of the funding will become clearer. We will also have a new government after the May election, so there will probably be more clarity then around funding for the rest of the year and what the priorities will be. But also it gives us a quarter in which to really start to implement some of these changes and give us a better indication of the level of savings that we believe we can make going through the rest of the year. So my intention is to propose a set of Q1 budgets to the board, and that's what the paper sets out, and that we come back at the July board after Q1 is finished, and we review where we are in terms of funding, review where we are in terms of savings delivery, and obviously a wider review around what the world looks like in terms of COVID response, COVID recovery, and the ability to push forward on some of the priorities in the annual plan. So it's with that in mind, really, that I'm proposing the budgets that we delegate set out in the paper. I've also proposed that we set a small contingency aside, and this is effectively out of the sort of COVID funding that I'm assuming. And this is, again, really just to deal with some of the uncertainty that we will be going through during the next few months. And if I just give you an example, which hopefully helps illustrate this, we will be looking probably to extend our use of the independent sector going into the first few weeks of the next year. And this would allow us to commit some of that contingency or reserves to allowing us to do that while we get more clarity around what the recovery part of our plans looks like going forwards. So perhaps if I can just pause there. There are some recommendations in the paper. Some include re-providing funding for our NCNs where they weren't able to commit funds this year. But perhaps if I just pause there, Chair, and I'm happy to take any questions or comments. Thank you.
Thank you very much, Glyn. That was quite clear. Could Louise ask a question?
Yeah, thank you, Jay. Thank you, Glyn. My question's around the pathways, and yeah, it might be linked in with the annual plan that we're going to discuss later. I just wondered, some of the pathways will need to be changed very quickly to adjust to the changing needs of health at the moment with COVID and everything. And I just wondered how quickly the financial funding and plans would actually, what that timescale would be. I know this, what you're describing now is for a year, is for the upcoming year. I just wondered how quickly we would adjust our plans and our pathways as and when they're needed, or will it take a longer time span to activate those?
Okay, so no, I mean, it's a really good question. I think, as you can see, I mean, some of these are key priorities in our annual plan. So I think on the basis that we support those as a board, and we have summarised them at the end, some of these are one of our sort of 5 key priorities. I would expect some of that to move very quickly, and we don't necessarily have to do all of the work on redesigning a pathway to be able to implement some of the changes. So, for instance, if we wanted to provide more resources to members of the public around self-care, that's something that we could do without necessarily having to implement all of the other changes around the pathway. If we chose to invest in some community services, knowing that that would help address some of the risk that exists with patients who are either perhaps sitting on a waiting list or maybe coming into the system for healthcare, potentially we'd be able to implement parts of that. I think it's really important that when we develop these plans, though, Louise, that we're clear about what the service change is, what that means in terms of workforce. So in some cases, there may be a heavier reliance on some of our allied health professional staff as part of these changes. And then alongside that, what are the financial assumptions? Some of it may require some investment, but we'd also expect to look at where we can release resources to allow that to ensure that we've got sustainable services going forward. So I really think we can make some rapid progress on this if we consider these to be organisational priorities.
Okay. Chris and Paul.
Thank you, Anna. Thanks, Glyn. As you know from previous discussions, I've supported the overall approach of the way you set out the budget for 21-22. You've sort of covered some of my questions and comments, and I suppose it's tied up, isn't it, with the uncertainty around Q1. But you mentioned in your report that we are going to use health outcomes to inform the way in which we allocate resources. And I just wonder where you think we'll be at the end of Q1 in being able to use health outcomes to inform resource allocation. And secondly, the 25 million opportunities, I understand, as you say, that it's complicated, but I think the board should be, I think when you report at the end of Q1, the board should have some idea of the analysis between what's actually cash releasing, what's productivity and improve outcomes, and how that's going to inform resource allocation for the rest of the year. I think we need to make it a bit less complicated than it is at the moment. Otherwise, I'm not sure how the board is going to be able to see that we are allocating resources differently to the way we have in previous years. So that's probably a comment around the questioning, Glyn, but your immediate reaction to how well placed you think you'll be at the end of Q1 to have that conversation with the board.
Yeah, no, thank you, Chris, and I absolutely agree. I mean, both in terms of your comments and questions. If I can perhaps just deal with the outcomes part first. I know you asked about that. I think as we go through next year, we have a certain amount of intelligence around outcomes for some of our pathways. So for some of the MSK pathway, we already collect outcomes. We already have an understanding of some of the things that we might do differently as a result of those outcomes. I think similarly on elements of our eye care pathways, we already collect outcomes for things like cataracts, and we're doing another exercise to update some of the intelligence on health outcomes for cataract surgery over the next month or two. So I think in some of the areas we've got quite good intelligence that tells us that actually there are a proportion of patients who have surgery, cataract surgery for instance, and as a result of that don't see any improvement in their health outcomes. And that has led to looking at how we can better triage patients earlier on in the pathway to see if cataract surgery is appropriate for them. So I think we've got individual examples of where we can do that. I think where we need to go next, and we're probably reliant on working nationally with the new Digital Healthcare Wales Authority and other health boards, is to have an organisational wide system that allows us to collect and measure outcomes easily across any pathway, any service that we commission or provide. And at the moment, we don't have the IT capability to do that easily at scale. So we can do it with some concerted effort across individual pathways, but at the moment we don't have that ability. And I know that there is a national piece of work going on to try and be quite clear about what a system would look like that would enable us to do that at scale, and how we can then commission that with a supplier who can provide it. There are very few sort of providers around that are able to do that at the moment. So I think that's where we need to get to next, if we can seriously look at measuring outcomes across the whole of our population, across a range of pathways. To then pick up your point about savings and efficiencies, I mean, you're quite right. I mean, it does sometimes get a little bit blurred around when is a saving cash releasing, when is it just improved efficiency or improved productivity, and you don't actually see any sort of financial cash fall out of the system as a result of doing it. At the moment, I would say in terms of the £25 million opportunity, I would probably describe certainly 13 to 14 million of it being cash releasing. Those are things that we can do more cost effectively without impacting on care to patients, but we would actually see a reduction in spend by doing it. Probably the other sort of 11 to 12 million is a little bit more blurred around whether it's improved productivity or would enable us to potentially reinvest resources elsewhere. So that gives you probably a broad split of where we are at the moment. And I think once we're clear about some of the service plans, so being clear about what our service plan is around MSK and eye care, for instance, I think it will be a lot easier for us to describe these are the cash releasing savings that we think we can generate. These are the resources that we would be looking to move around the system, if you like. So potentially disinvesting in one area, but knowing that we've got to invest in another area to deliver those improved health outcomes. So it's probably broadly a 50-50 split, maybe slightly in favour of cash releasing savings at the moment. But I think as we do that work, it'll become clearer, and I absolutely agree. I mean, I would like to have more clarity myself in terms of what is cash releasing. And I guess that comes back to my point about setting budgets for Q1, trying to get some of that clarity so that when we come back in July, we can hopefully all have more clarity around what the financial savings are and what we're looking to reinvest to improve health outcomes. So I hope that sort of answered your question, Chris.
Yeah, I think certainly on MSK and eye care, it'd be helpful. Well, a question, do you think by the end of Q1 we'll be in a position to do what you just said, which is to say, well, these are the opportunities and this is the implication for allocating resource for quarters 2, 3 and 4?
I think if we commit to our annual plan and we implement those, or start doing the work on implementing those pathways, then I would expect by Q1 to be able to do that, yes.
Okay, thank you.
Thank you, Glyn. Paul?
Just to say, first of all, to thank Glyn and the team for the work they undertake on the finance and budgets work, because I think we're in a relatively positive position compared to others within the sector. So I think, first of all, to accept that. I mean, the whole approach that has been suggested and what's been recommended makes eminent sense, and ultimately it will be to tie the budget to the priorities, and I think that's incredibly important. I do agree with with Chris about the future-proofing, so we have sustainable services and to have a focus on savings that then can be reinvested for the future. So that's something I think is being looked at. But the position we are at the moment is April to June, first quarter to agree a position, and then to basically in July reflect, review, and then make decisions then. And that seems to be, particularly with the political situation as well, I think makes a lot of common sense. And so I would wholeheartedly support the recommendations put forward, because I think it's measured, proportionate, and I think is sensible in the current circumstances. Thank you,
thank you, Paul.
Are there any further questions? There are not. Are you content to adopt and approve the Q1 budget, pending further enlightenment on what allocations might or might not be forthcoming, and to allow the work on savings to be undertaken?
Yep.
Yes.
Yes. Thank you very much. Thank you, Glenn.
Thank you.
Thank you. Could we move on then, please, to the strategic risk report, Judith?
Thank you, Chair. So, as board members will have noted, the strategic risk report has been completely recast through and informed by a number of sessions that the executive team have undertaken around the risk register, aligned to the annual plan and other aspects of clearly that are affecting our services and our organisation at the current time. I understand that it was the chair of audit who asked that it come to the board today. So happy to do that, and aligning it to the discussion that we would have had on the annual plan and on budget setting it was probably a wise ask from Shelley. So thank you for that. Just to say that the executive team have had a number of sessions to go through the approach to risk, the risks themselves, recasting the risks based on what we've learned and what we understand the situation to currently be across the health board, but also, as I've said, to read across to the annual plan. The revised format is set out in terms of the risk on a page. On page 3 of the report, we indicate those risks that have now been removed from the risk register, or reworded or rewritten in some way to better reflect our current situation. And also there are a number of risks that have been reframed on that basis. There are currently 17 risks on the risk register. As I said, 5 have been removed, 8 have been reframed as well. It probably still needs some adjustment as we go forward. One of the conversations I was having with the chair this morning in terms of our revised governance and committee structure is just making sure that the right risks are assigned to the right committee, and that might need a little bit more work with the committees as we move forward. But Chair, here for a review by all the board members, and just noting that it might be subject to some slight amendments as we go forward into the new year.
Thank you, Judith. That was very helpful, and I think we all welcomed the recast reports, and particularly the reframing of some of our risks, which more appropriately reflect the scale of the issue that we're trying to manage. I have Shelley, then Chris.
Yeah, thanks very much, and thanks, Judith, for that the overview. I've had the opportunity of discussing this with Richard and Danny in the different approach and what have you, and I think this is really very, very, it's a great step in the right direction, and certainly from my perspective, the clarity on the recasting of those risks is definitely, it's easier to understand, because I think before there were lots of risks within risks, and this makes it clearer. And I agree with you as well. I think there probably does need to be more work, and I think that will happen because it's going to be an iterative process as we're going forward. You've also covered the point I was going to make, that some of the risks at the in these schedules, I would query whether they're in the right areas at the moment, but that very much is, I think we've got to look at that in the line of the later document we've got on terms of reference. So there may be some changing around there, but definitely a step in the right direction. And I know that the audit committee will obviously be having these reports back regularly to have a look at. So, I think certainly certainly I would say within the next 6 months, I think this will all help to inform our border assurance framework as well, which obviously is another thing that we need to just get up and running. So thank you very much. Thanks, Judith.
Thank you. Yeah, thanks, Shelley. And I agree. I think we've got a line of sight now through the audit committee to a board development session to the board assurance framework, which will come to the board in May. So I think, yeah, I think it's good. We're slightly ahead probably of where we might normally be. So that's good. So, but I think there are just a couple of more tweaks around where those committees and risks align, but we can sort that out fairly quickly now, assuming that the terms of reference get agreed later on today.
Thank you, Chris, and then Paul.
Yeah, thank you, Anne, and thank you, Judith. I think this is a good step forward in terms of making it a more straightforward process. And I think the 4 things that the board needs to keep coming back to, because I think in the past, not just in this health board, but other organisation, risk management systems tend to be sidelined and not part of the way in which the board does business. And one of the things that I think you more than hinted at in your opening remarks is that the executive team has spent a lot of time over the last few weeks in recasting the risks, and the approach that we now are suggesting is a much simpler one, and one that's going to enable the board to engage better in assurance and risk management. So the 4 things I think we need to keep coming back to as we go through this is keeping it simple and not overcomplicating it. As you say, Judith, linking it very clearly to our corporate objectives in our annual plan and IMTP, focusing on what actually happens as a result of us managing these risks, being clear on both the outcomes and the outputs and the impacts of the way we're managing risk. And the 4th one is the test of it all, is that the board is continuously engaged in this new risk management approach rather than something that it just dips into at the board. So your point about it needs to very much be part of the work programme of each of the new committees is an important one as well. So very much support what we're suggesting as a new way of engaging on risk.
Thank you, Chris. Anne, have we lost you?
No.
Oh.
Somebody's muted me, which wasn't very helpful.
Yeah. Just say, can I support what Chris has also said? I think it is important to join up this whole important area of risk management with the committees, and I think for each committee to have responsibility for some of these so they can report into the audit committee makes it far more joined up. But I did want to say I thought these strategic risk profiles, a new format, I think they're a new format, I think are incredibly helpful to understand as well. And I think including the 4 harms of COVID, I think is also another sort of added sort of sphere to it. So all in all, I think that we're on this journey with regard to this particular issue, with more discussions to come forward. But just to say to you, Judith, I think this is a great way forward, and I think it does help. I think IMs particularly to understand the audit process and how this has to be combined together into one conversation, because I think sometimes audit and risk can sometimes be siloed, and I think what we want to do is to engender this back into main organisational sort of understanding and make sure we've got the entire conversation together, and that then would support Shelley and the team, chair of the committee, and those involved with audit and assurance, so that we've got one conversation going throughout the organisation rather than these siloed conversations. So just to say well done, and I wholeheartedly again welcome this approach.
Thanks, Paul. And if I could just pass on that well done to Richard and Danny, and I will make sure I do that. So thank you.
Thank you very much. Are there any further questions? If not, we are happy to endorse this new risk management approach, and we will have a further discussion about the allocation of risk in an effective way to the committee, so that everybody's clear that all these risks are covered and being scrutinised. Many thanks. Thank you very much. The finance report then, Glyn, you frozen, by the way, but we can hear you.
Okay, can you hear me?
Yep.
Yeah, the irony is I'm next door to you, Chair, so...
Yes.
Okay, so hopefully people can hear me.
Yeah.
Thank you. I can see a few nods. Thank you. Okay, so I'll keep this fairly brief because as we head towards the end of the year, I mean, I think there's more certainty around our funding for the year and where we're heading, both in terms of the revenue resource limit and also the capital resource limit. So you've got in the board papers the financial positions based on month 10. Since then, we've reported on month 11, and I think, as Nicola said, we have 7 days to go. We're almost at the end of the financial year now. So month 11, the surplus, we reported a year-to-date surplus of about 176,000, so slightly less than before. We are, however, seeing slippage in some of the spend programmes, both in terms of some of the COVID-related services that we provided, but also some of the services that we would normally provide. So based on our original Q3/4 plan, we were making certain assumptions around the level of surge capacity that we would need during this period, the level of workforce that we would need, and that obviously translates into a financial estimate or forecast. So if anything, we're probably seeing some slippage on that as we head towards the end of the year. That's helpfully, I think, given us an opportunity to use some of that funding to spend in areas that would, I think, help us as we go forwards next year. So, for instance, we've been able to purchase additional diabetic pumps for many of our patients. And when you look at sort of improving health outcomes for our population, hopefully trying to keep people out of hospital, to avoiding acute admissions, that's an area where hopefully we've been able to do that and spend money in a sensible way. At the moment, we are forecasting financial break-even against our revenue resource budget. What we have seen during the last month or two is an increased use of agency workforce. So again, I think as we start to see ourselves coming out of COVID over the next month or two, we would hope to see our reliance on agency workforce diminishing as that happens. And obviously from a financial point of view, we would expect to see some of our workforce costs come down as a result of that. In terms of capital, again, the month 10 report highlighted a potential deficit problem, but this was more around trying to confirm the final funding allocations for capital spend linked to COVID, which we've been able to do. So in the last week or so, Welsh Government have now confirmed those funding allocations for this year. And I think, as Nicola described earlier, it's more about how we manage the funding that we've got available around capital investment this year, making best use of it, and being able to bring forward some of the things that we perhaps going to do next year where we've got slippage in capital schemes. So again, we're forecasting a balanced position on capital, but it is very much about just trying to manage the funding and spend between the two financial years at this stage. As far as risks and opportunities are concerned, I've outlined a number there, but I think, as I said, as we approach almost the last week of the financial year, I think most of those we're sort of pretty certain where we're heading. And probably the one that I would just sort of highlight as being unusual to most normal years is the financial provision that we've made around untaken annual leave, and that's currently valued at just over £20 million, for which we've got funding secured, and we would be looking to provide for that in our year-end financial position to recognise the significant amount of leave that people have been unable to take this year because of the COVID pandemic. and obviously because of the opening of the Grange University Hospital as well. So happy to pause there and take any questions. I know that Emrys did ask a question online prior to the board meeting, so I'm happy to pick that up at the appropriate time.
Thank you, Glenn. And I'll read it out so that everybody knows what it is. But Paul wishes to ask a question first. Paul? Oh, well, I'll ask Emrys's question first then. He notes that there is a significant difference in the schedule of care savings, yet we know that the scheduled care activity was reduced during COVID. So why is this? Now, in part, I think you've dealt with it, but I think for the record to reiterate the explanation, Glyn, might be useful.
Yeah, so I think the important point around Emrys's question is what is the risk, and I think this year the risk there is very little risk, because what we've actually seen is a significant level of costs avoided this year, because we've suspended a lot of our routine elective care. So in effect, whilst scheduled care division haven't delivered that level of savings, they've not spent the money because they've not delivered many of those elective services. So if you look at their financial position, they're actually currently reporting a small surplus, which is actually quite unusual for scheduled care division. So in terms of this year, it doesn't present a risk. Clearly, there are consequences of not delivering that elective work as well. Going forwards, the risk is that they would potentially try and resume services in exactly the same way and incur those costs, and if we're not delivering the savings, that would result in a deficit. And that, as you rightly say, Chair, that ties back into the conversation about delivering savings and making efficiencies around some of the pathways that we're looking to redesign. So if we take the two pathways of MSK and iCare, both of those scheduled care division play a very prominent part in delivering those pathways. So that's where the risk lies going forwards, and why it's so important to implement those new pathways and make better use of resources as we do it. So I hope that answers the question sufficiently.
Thank you, Glenn. Paul?
No, mine that's been answered. Thank you. That was what I was going to ask. That's absolutely fine.
Oh, no. Thank you. Tish?
Thank you, Chair. It's not so much a question, it's just a comment that at the beginning of this meeting, you and Judith said a huge thanks to our staff for the work that they put in over the year. And I think this in excess of £20 million of unused or unused annual leave gives a figure with a pound sign in front of it to demonstrate the amount of extra effort that our staff have put in. What we consider as a board goes right across everything we do, and we don't compartmentalise the work that the staff do in one area and finance in another. And I think this just highlights again how much work, how our staff have consistently gone that extra mile over the last year to support our work and our public. So again, thank you.
Thank you, Tish. A really valuable comment. That's very welcome. Are there any further comments, questions to Glyn? Okay, we pass on to the performance report then.
Okay, thank you, Chair. And again, hopefully people will have found the performance report this month fairly informative. We tried to include in the narrative a little bit of an assessment of where we currently are, both in terms of reporting against performance targets publicly, but also I think just sort of recognising that as hopefully the number of COVID patients in our hospitals continues to fall, we will, and we are actually now looking to resume a lot of the routine elective services. And we should start to see this reflected in improvements in our performance targets over the next couple of months. So the performance report that you've got, in most cases, gives you the performance measures up to the end of January. And obviously since that time, we've seen sort of the draft performance figures for the end of February, which again show some improvements in the number of people waiting for diagnostics or elective treatments. So we can see that we're beginning to move in the right direction, but clearly we do need to recognise that we, you know, as a result of the pandemic, this has built up quite a significant waiting list for a lot of our elective services. So this starts to get into the recovery bit about the time it will take to start reducing those waiting times significantly, and how we approach this very differently going forwards. So the report focuses primarily on elective services, access to diagnostic and cancer services, and again we've got the new single cancer pathway measure that we are now being measured and reporting against, but also highlighting where we are in terms of unscheduled care and stroke care. And then I think importantly, and this will become increasingly important over the next year, is access to mental health services. So I wasn't going to go through those in any detail, but I think as we go through the next few months, it will be important that we keep the board informed of our plans around not just restarting services, but also how we start to get into the recovery part, which I think is very much linked back to our annual plan priorities and about doing things differently, understanding the risk to many of our patients and people in our communities, and using that as the basis for prioritising care. So again, happy to pause there and take any questions.
Thank you, Glenn. Shelley?
Sorry, I don't know if this is for Glenn really, Chair, but it was just in relation to the waiting lists and the new ways of working, which we've just been discussing now. I just wondered what the communication was going to be in relation to patients that perhaps have been on waiting lists, but because things are now going to be approached differently, their treatment programme might actually be different from what they were expecting. So, for example, I don't know if somebody was waiting for a knee operation, but actually they haven't had it and they're not actually feeling any worse. There may be an alternative treatment. And I just wondered how, as a health board, we were going to be approaching that, because I guess that might be difficult for some patients, you know, thinking that they're not getting the treatment that they should have had, etc. So I obviously support everything we're doing, but I just think that we need to make sure that we've got a good communication plan in place, not only individually with the patient, but perhaps something wider as well. Thank you.
Claire, would you like to come in?
Yes, thank you. So yes, what we've been concentrating on up until now is some really good housekeeping, as well as concentrating on booking our cancer and urgent patients, some good housekeeping about all of the other patients that are left on the list, so that we know that we haven't lost any discipline about making sure that we've got good, accurate records of patient numbers that are waiting. The next stage of this is about how we then meaningfully communicate with patients. So not just having that constant, do you want to remain on the list, but also having some two-way dialogue, either from a clerical perspective, but also from a clinical perspective, to make sure that patients, we can help manage their expectations around this, but also where there is opportunity for patients to maybe help improve their well-being while they wait on the list, but also some decision making around, some honest discussions really about the length of some of our waiting lists, particularly for some of our long-waited routine patients that aren't necessarily in the higher Royal College of Surgeons category. So we're just working through that, and Welsh Government are directing us on some of this through their Plan Care programme. So that is all part of our work plan in recovery, but we're definitely starting to see a return of patients wanting to come and attend appointments and engage with us. Some are still a little anxious around COVID, some are waiting for second vaccine, but we're definitely seeing, certainly in the cancer arena, a real increase now in demand back again. So now is the time really to start having those engaging conversations and honest conversations with those patients waiting on our lists. And we've got some good ways of doing that through doctor, but also the way that we're trying to reorganise some of our scheduling and booking staff so that patients don't just leave messages for us. We have that honest conversation with them.
Thank you, Claire. Just leading on slightly from that, I noticed that national reporting has started again for RTT diagnostics and therapy, and ours is, well, everybody's is going to look pretty red for the next period of time. And I wonder, and I don't expect an answer to this now, but I wonder, in order for this to be meaningful for us and the services that we are delivering in different ways, we should think of using a different set of performance indicators to try and ensure that we can keep up with a true indication of performance and outcomes for people that we've never really had the opportunity to do in the past, because we've always quite rightly stuck to national guidelines. But you know, if we could use something like the RCS criteria about when are people being seen along those criteria, it might be more informative to the board and to the public than having lots of reds, because we know we've got a waiting list and we're dealing with it as appropriately as possible. And I endorse your ideas, Claire, on this and those of the executive. But I think it would be really helpful to have some thoughts on an alternative for the future. But I'll just leave that with you, Paul.
Just wanted, I think you touched on it, Claire, and I just wanted to sort of just to unpick the sort of utilising the range of varied sort of patient engagement and consultation, and to hear patient voices, really, because I think one of the outcomes of the pandemic has been utilising virtual conversations with patients, whereas prior to that there'd been sort of all sorts of things stopping that from happening, really, or appeared to be anyway. So we've now got this opportunity, and I think rather than expecting patients to go to buildings, there's an opportunity to engage with them prior to that. So, and I think there's probably some work sort of a conversation to be had with the communications team as well. We've done a brilliant job over this COVID period to just sort of make patients aware of the range of what the possibilities might be, just to unpick that. Is that in line with what's planned?
Yeah, so as part of the evaluation of what we've been doing through COVID, particularly around outpatients, we've been trying to evaluate the impact of virtual appointments, and we've been talking to our patients around, well, has this worked for you? So it's definitely had some really good feedback for a large group of patients, particularly around things like the timing of appointments, the ability to actually pin people down to the discussion about the condition that they really want, that capture that 5 minutes of clinical conversation with the expert, but also things like travel time, not having to use public transport in a pandemic, parking, all of those usual things. So a lot of our patients have been, really supportive, but for some groups, particularly, we've had the CHC report on people feeling forgotten. We've, the loneliness for a lot of our chronic conditions patients and the elderly. Their visits to hospitals are part of their it's part of their social structure now as well. So it doesn't fit all, and there are definitely parts of anyone's pathway where sometimes people, clinicians have to put hands on people. So it's that measure really of making sure that we.
Is that a problem at all?
Yeah, I think in a bizarre way, from that perspective, COVID has helped us because we've been able to tap into equipment that has enabled our staff to have no excuses really than to be able to run clinics and MDTs, etc. in this way. So we've definitely made the most of the innovative funding available to us. We just have to bear in mind that that's not always reciprocated on the other end for patients, and they may not be as agile, but there are lots of organisations that can help us with that, and the Community Health Council have certainly been very helpful in their offer of approach.
And I have to say 47% is incredibly encouraging, and thank you and to the team and the people involved in sort of allowing the patients to have that opportunity to be able to get their feedback much more quickly than they would otherwise. So that's really good. Thank you.
Thank you. We have a comment from Helen about the helpfulness of the Aneurin Bevan website on what patients can expect. So thank you for that, Helen. Are there any more comments? No? Well, we accept the performance report. And can we move now to the nurse staffing levels extension? Rhiannon.
Thanks very much, Chair. This paper is really for information, but it is an important one in terms of the Nurse Staffing Levels Wales Act. The Act has now been extended to the paediatric inpatient wards. This was actually an anticipated extension to the Act, so it's one that we've been working on for some time, and it's just one of a number of work streams associated with the Act, to include health visiting, district nursing and mental health. The board will recall that Wales is the only country in Europe to have legislation for nurse staffing levels. And the purpose of that is to ensure that we've got the right staff in with the right skill mix, and particularly registered nurses, to ensure optimum patient care and the right patient outcomes. We've had a lot of preparation in terms of the extension of this Act, and we've had previous papers in relation to our compliance to paediatric principles. We've got a workforce planning tool and the Welsh levels of care for patient acuity, all of which enables us to determine what the consequent staffing and skill mix should be. The Senedd passed the extension to the Act in February this year. The go live date as identified within the plan is October 2021. I'm able to confirm that the Health Board is in a really strong position in relation to the implementation of the extension of the Act from all the work that we've been doing both locally and nationally. And from October, we are confident that we will be compliant, as we are in terms of medical and surgical wards, which we already report on. So the board is asked to note the extension and our Health Board position. And at this juncture, I just would like to acknowledge the work of both divisional nurses, Chris Overs and Helen Morgan, but also Linda Alexander, who's the Assistant Director of Nursing, who leads on this work stream. It's been a huge amount of work, but a huge amount of work that puts us in a positive position from October to ensure compliance. Thank you.
Thank you very much, Rhiannon, and thank you very much for the hard work that's been undertaken in getting us to this positive position. Mm-hmm. Are there any questions to Rhiannon?
Well,
no. Then we adopt your recommendations and reports. Thank you. Oh, smoke-free legislation. Well, this is interesting. We've been trying to do this for 40 years.
Thank you, Chair. Well, we've done it now. So the paper is to provide the board with assurance on how the Health Board is implementing this new legislation, which came into effect in Wales on the 1st of March. It's actually part of the Public Health Wales Act, and it makes it illegal to smoke on hospital grounds and in outdoor public places for children and young people. And the public health objective is to denormalise smoking in public places, and it's again links back to the well-being of future generations and trying to make it normal for young people not to start smoking. So the paper describes the progressive approach we're taking to implementation, given that there wasn't much of a lead-in time to this legislation coming into effect. And so we are following the engagement, education, encouragement and building up to
enforcement approach that is normal practice for the police and local authority regulatory services when new legislation comes into effect. And the paper sets out the phases that we are following. The first phase was the legal requirement to have signage in place on the 1st of March, which we met. And the second phase between now and the end of April is to make staff, public and patients aware of the new legislation, and also to develop site-specific implementation plans, because the legislation applies to every hospital site. In the past, we've tended to focus our smoke-free efforts on our acute sites, and one of the things that we need to do with this is bring all our community and mental health hospital sites into the net as well. So once we've done that initial engagement and education and encouragement, the next phase will start to see the presence of local authority enforcement officers, who are the officers who legally can issue the fixed penalty fines. To start with, they will be present, we'll make sure they're highly visible, and they will offer verbal warnings leading up to starting to actively issue fixed penalty fines of £100 for smokers smoking on hospital grounds. It is of note for the board that failure to prevent smoking on any hospital grounds could result in a £2,500 fine for the health board. But our implementation plan has been shared with the local authorities, who are content with the approach that we are taking. And in the paper, there's more detail about the elements of the implementation plan, but the paper is there to provide assurance for the board, and I'm happy to answer any questions.
Thank you, Sarah. Thank you for that. Has anybody got any questions?
I was just going to say, Anne, that I think this is a very sensible approach. I mean, I can remember chairing a multi-agency group in 2007 with regard to when the smoke-free legislation came in. And I think, we are 13 years on with regard to hospital sites. So I think that the engage, the educate, the encourage and the enforce, having a graduated level rather than going straight to enforcement, I think is absolutely right, because it's conversations then with individuals to try and get them to change their behaviour or to ensure that they are aware of what the current situation is. So I think this is a very measured, sensible approach, and I would support it, and I thank all involved, because I think it's important that we get this right.
Thank you. Tej?
Thank you, Chair. It was just to echo that, actually, that my comment would be that it's a good balance for me between enforcement, which we have to do, but also encouragement and support, because we know that this is a difficult nut to crack, and we just have to keep on keeping on with it, and it is consistent with our wider building a healthier Gwent work, and that education, support, and trying to motivate people to change their behaviours is fundamental, and just enforcement isn't going to work. So thank you.
Thank you, Tej. I would agree with that comment. Pippa?
Yes, I'm fully supportive of the paper. I think that probably goes without saying for all of us. I was wondering about some of our mental health facilities, because we know that for particularly some of our patients, that smoking is very much a way of life, and how do we I'm not quite certain, if you remove smoking from the lives of some people, what impact that will have on them. So is there a question of any leeway for those particular facilities? So I think that's my one point. The other point, of course, is just about the Royal Gwent, which we all know. There's a lot of smokers who are not strictly on hospital grounds because they just nip round the corner, and whether or not that's something that the enforcement officers would be able to look at in time. So that was kind of my two comments. But yes, great to see. And like Tej, I'm really heartened to see there's a range of options on offer to tackle this.
So on the mental health inpatient wards, Pippa, we already have designated smoking areas outdoors, so we don't have indoor smoking areas already. So the paper is proposing that we maintain the designated outdoor smoking areas in those secure garden areas. There is a concern has been raised about mental health patients presenting as an emergency to our emergency department, and how we manage that. So there's work to be done around a clear approach to managing people attending our emergency department who may be in a state of distress. So that's on the, we know we need to do that, and it's all about being proportionate, isn't it? And yes. I think what we're talking about is patients for whom clinically there may be an assessment that actually they should be allowed to smoke, and I think that's probably the direction of travel.
That's great, thank you, Sarah.
On the Royal Gwent and off any of our sites, the legislation applies to hospital grounds, but our existing policy is very clear about staff not smoking in uniform, and therefore needing to leave the site and come back and change. And so I think there's an element of what's already in the policy that we can perhaps be enforced more strictly than we have done. And then with the local authority enforcement officers, the other bit of legislation is the litter element, which again we haven't really used, but it is illegal to drop cigarette butts. So I think there are, but the legislation does only apply to the designated on a map hospital ground.
Claire, did you want to add something to that?
Yeah, it was just on the Royal Gwent particularly, but all of our sites are plagued by this really. But from a Royal Gwent perspective, we've had a real focus on that over the last 3 weeks, particularly down the very public area alongside Bellevue, and myself, the site management team there, and the local enforcement officer within the site team there have done some really had some really challenging conversations with groups of staff. So I think it is an ongoing battle, but I think that the skills that the team have around negotiating and advising staff around what and what isn't acceptable, and the fact that there's a closer look, I think we will see a change there.
Thank you, Claire. Did you want to add something, Sarah?
Yes, because that principle of a senior site lead is part of the implementation plan, and I have to commend the site leadership at the Royal Gwent because they've really embraced it, and then the part of the plan is using the Make Every Contact Count approach to build staff confidence to approach people. Yeah. So it's all part of making it normal to challenge, normal not to smoke, and sort of shifting that balance, so that the actual enforcement element hopefully becomes fairly minimal. And I think with most new bits of legislation, you think about new speed cameras somewhere, there'll be, at the point we start actively enforcing, there will be some people who have perhaps thought it wasn't ever going to happen, and then I suspect we'll get over that, and I'm hoping that by this time next year it will just become the way hospitals work, and people know that there is no smoking and they don't expect to smoke, and what you've got is an implementation plan to get us there.
Thank you, Sarah. Louise?
Yeah, thank you. Yes, I also welcome this the new smoking legislation, in support of it. My question was around the mental health garden areas. I'm aware that some of the gardens might not actually comply to the distance they're meant to be from the buildings. I'm just wondering whether or not we're going to have some time for adjustment to be able to address those issues, because I know you're in discussion with local authorities regarding this issue, but because that's not of our making, is it? I mean, we've provided the areas for our mental health patients as we would normally, but the new regulations coming in now might have scuppered that a little bit for us.
I think the word in the legislation is reasonable, and I think it's the local authorities are content we're making reasonable progress.
Oh, that's good. Thank you.
And therefore, if there's a physical adaptation reason why we can't do something slightly more quickly, then but we're working to do it as quickly as we can, then I would suggest that is reasonable. So our local authority colleagues are working with us very in the spirit of what we've set out in the paper, really.
Thank you, Sarah. Thank you. So we note this and we look forward to receiving an update on the way in which it's being implemented and any issues that are arising subsequently, please, Sarah. Thank you. The annual audit report, Audit Wales, we're joined by Gabby. Welcome.
Good morning.
Good morning.
I'm attending to present the Auditor General's annual audit report, which we presented to the Audit Committee in early February. And this is a report that we present once a year to the board, and it summarises both our financial and our performance audit work over the course of the year. In 2020, we obviously undertook our accounts work, and we only did a limited a number of performance audits, largely because of COVID, because we scaled back the progress that we made on some of our work. I wasn't going to go into it in detail. One of the tables I did want to highlight at the back of the report in Exhibit 3, since we produced the report before Christmas, we've actually made considerable progress on a lot of the work that was still outstanding at the end of 2020. Although some timetables for delivery of audits like the quality governance work will have been extended, because through your discussions earlier in the day, you were talking about recovery of clinical staff as a result of COVID. So our work timetable for delivering is all being agreed with staff to make sure that they're actually able to support the audit in a timely way, but one that doesn't actually increase the burden on them. So I'm happy to take any questions.
Thank you, Gabby. Are there any questions to Gabby?
No,
Might we have a...
They're very good. I think there's been it's very helpful to us to have that, Gabby, and I think there's very good working relationship with your team, and I think that this is very helpful to us in terms of our work planning. I'm sure the audit committee will have found this really useful and really helpful.
Hopefully next year's report will have far more covered in it, because we will have been able to make more progress.
Yeah. Thank
you. I think it could be helpful, Gabby, on your work ongoing. Obviously, some of these times have gone past. For us, the board, to have just a note on what the revised timings might be for the receipt of the report, and for the independent members who are not part of the audit committee, what the scope, just a very short paragraph on what the scope of each of the reviews might be. Would that be all right?
Yes, I can send that to you.
Thank you. Are there any further comments to Gabby?
Well done.
Well, thank you very much for this, and we'll keep an ongoing eye on progress. Thank you.
Thank you.
The review of the committee's terms of reference, we have received these. I know there are a number of comments about them. So before we get to any detailed comments that people might wish to make, might I suggest that these draft terms of reference are adopted to be reviewed by the committees at their first meeting, and for them to suggest any updates or slight changes that might be required to cover the scope, and that we will do a review of the risks and make sure that it is clear which committee is managing which risks, so that there is nothing dropping through holes. Additionally, I've asked Gabby to undertake a review for us in December on how the new arrangements are working, and I'm very pleased that she's been happy to do that, because I think it'll be very helpful. But has anybody any comments, Paul?
I think actually, I mean, I've looked through. I'm not on all the committees, obviously, but I've looked at these papers. There's a uniformity, a standardisation. They make clear sense, and what you've suggested, Anne, I think also is absolutely right. That let's go with this. I think this is a it's a leaner structure, it's a rebalance and a resetting of governance. We are covering all we need to cover in a slightly different way. I think it's a much more improved, less bureaucratic sort of strategic sort of oversight, and I think that getting the committees to review them at the first meeting would be absolutely right. So I think that let's go with it and let's move on. Thank you, Paul. Chris?
Yeah, thank you, Chair. I think your suggestion that the committees review their individual terms of reference is very sensible. I do have a couple of points, though. One is on first reading, the terms of reference for the new planning and strategic change, which I can't remember off the top of my head.
Population health, yeah.
On first reading, there does seem to be a bit of potential overlap with the audit committee, particularly around some of the governance and risk management arrangements. So maybe when we review that as the first next meeting of that committee, we can just bear that in mind, and the audit committee can do likewise. Yeah. I also, unlike Paul, I think I do think the scope for simplifying the objectives of each of the committee, they are quite wordy, I think. Particularly, I've looked at detail of the audit committee, and I did suggest to Richard Howells that he and I could get our heads together before the audit committee to try and simplify some of those. Just to make clear, particularly as we're now running with fewer committees, it needs to be clear what the responsibilities are. But I think all that can be picked up in the review that you've suggested, but maybe each of the committees can look at their terms of reference in that light as well.
Yes, very helpful suggestion, Chris. Thank you. Shelley? Yeah, that I obviously agree with all of that. And the one thing that I have asked Richard, and he's agreed to do, was at the audit committee to just give us an oversight, because obviously we have seen these together now on this paper, but they may change. But just a matrix to just assure us where we've had committees that have stood down, where those items are now going to be discussed, just so we can have clarity. And I think there is a bit around some of the audit stuff and the planning and strategy, as Chris has said, in relation to ICG and some of the performance, just to be clear about it, because what we don't want obviously is one, something falling between the cracks, but also something coming to audit committee and then actually going to another committee when we don't really need to be doing that. So I think that will really be helpful at the beginning of April to have that as well. So thank you very much. Thank you, Shelley. So if there are no further comments, might I suggest that we adopt the suggestion I've made, and we will have feedback at our next meeting on any changes that have been suggested and agreed by the committees. Yeah. And the further work on the allocation of the risks will be undertaken. Many thanks. Thank you. 4.8, key matters from committees. Have the chair, Shelley, have you got your hand up? Oh, okay. Have the chairs of the committees got anything that they wish to bring to our attention in this report? Okay, well, thank you for that. Can we now return to the annual plan, please? Nicola.
Yeah, thank you, Chair. And so I'm really pleased to present the draft annual plan for 21-22 and is seeking board approval for the plan so we can submit to Welsh Government by the 31st of March. As you'll all be aware from our discussions this year, the traditional IMTP process was paused last April as a result of the pandemic, and we moved into a quarterly planning cycle during 2021. And this is now, health boards have now been requested to develop annual plans by Welsh Government for 21-22 as part of this annual planning framework guidance that it issued out in December. The planning framework issued by Welsh Government very much kind of recognises the need to balance operational demand and being able to focus on that stabilisation and recovery phase, but in the context of the ongoing challenges and uncertainties that the pandemic gives us, really. So the plan is intentionally shorter than normal and really does try to acknowledge and capture the need for flexibility throughout the year as we continue to respond to the challenges of the pandemic. It's also supported by a detailed minimum data set, which I know we submitted a bit later, which gives a lot of quantitative information, particularly around some of the test, trace, protect service, vaccination, screening, capacity, particularly around hospital capacity, workforce and finance. And I know Glyn has picked up obviously the quarterly finance approach earlier on. Before I go into the plan in detail, I do want to alert you to a change that we're going to need to make to the minimum data set around workforce. There is a planned 2P transfer of approximately 50 staff who will now move from Aneurin Bevan Health Board to shared services that work for the laundry service. This is part of a change of responsibility for laundry services from health boards to shared services. And the decision to enact that from the 1st of April was made fairly short notice in April. So there'll be 50 full-time equivalent, and it's also important for the board to be aware of that change. So going back to the actual plan document itself, we've taken the opportunity, I think, given where we are in our Clinical Futures programme and coming through the last 12 months of a pandemic, to really refocus the plan to kind of right back to our core organisational priorities, particularly around that focus on population health and addressing inequalities, which I think we're all concerned will be heightened as a result of the pandemic. So we've adopted very much a life course approach, and I know many of you have had an opportunity to contribute to this, where we've identified 5 priority groups, very much taking that life course, starting with giving every child the best start in life, moving through to children and young adults, working age adults, to kind of the older adult agenda and ensuring people die well, making sure the end of life pathways are where they need to be. It also describes the key enablers that are critical to the success of delivering our priorities, ranging from, workforce, data and intelligence, urgent care, that whole focus on quality and safety. So a huge kind of focus on the enablers as well. We very much engage with staff across the health board, both corporately and operationally, and have taken the opportunity to link in with many other stakeholders, including the Community Health Council, the Regional Partnership Board, the Trade Union Partnership Forum. We've also shared this with Welsh Government, and I know many of you as board members through other committees and on a more one-to-one level have had the opportunity to contribute and shape some of this plan. We've also set out a new proposed approach to the delivery framework. Again, I think we're at a critical point, and it's timely for us to review our Clinical Futures programme structure and how that, alongside the annual plan priorities moving into next year, come together much more into one more robust delivery framework, focusing on transformation. And also, I've referenced in the paper that we are doing a bit more work around the outcomes framework, and I know we picked a bit of this up just now in the finance discussion. And the plan is for us to have a bit more time to shape that and think and discuss this at the next strategic planning committee on the 21st of April. So in summary, hopefully people will see that the plan is very much tries to acknowledge the challenges that the organisation and our staff in particular have been through in the last 12 months. The ongoing pressures that face us as we move through the pandemic, particularly around our test, trace, protect responsibilities, a very robust and important vaccination programme, our continued focus on infection prevention and control pathways, our response plans. But in addition, that need to be able to focus on a restart, a reset, reflect and recover, and also start improving our availability of services to those that we had to kind of put on hold, and be able to really start to tackle those, but with a real focus on transformation and not just reverting to traditional ways of working where we've really seen new opportunities. So hopefully the plan captures that. I think I also want to give credit to Chris Dawson-Morris, who I know many of you have met on the plan. I think he's brought a really fresh approach to the planning process for us, which I think again is very timely. And I know supported by Ethna Hunter and Jenny Keating, the planning team have done a fantastic job in turning a very complex system agenda into a very readable document, which tries to really focus on our key priorities. So hopefully the board is happy to approve the plan, and I'm happy to take questions.
Thank you very much, Nicola. Paul?
Just to say, I really like the format of this report. I mean, it's very engaging in terms of how it looks and readability, etc. And so the format, it reads well, and I think it captures all the key issues. The key question I was going to ask, I think you've answered, Nicola, which is who's been involved in the consultation over this. And I think you've talked about the CHC and you've talked about staff. So you've got all the people giving their input into it, which I think is important. And you've got the data set that will come forward, and I think what is important is that we can then use this annual plan and its priorities to then look at the budget setting and using it as an actually having a plan that we can utilise throughout the year. So I think that I think it's a great job, well done, and huge thanks to all that put it together.
Thank you, Louise.
Yeah, thank you, Nicola. As you're aware, I'm a big supporter of the Clinical Future Agenda, and I've been involved with it on a staff side perspective, as well as my independent role. My question's around workforce. When we go to care closer to home, obviously the numbers are going to increase with the workforce. I was just wondering whether we had a rough estimate on how much that would increase for the workforce that we need to take on, registered and unregistered staff, and obviously our involvement then with the third sector and local government and everything alongside this to be able to deliver care closer to home. So I don't expect you to have the answer today. I just wonder whether or not we've got a sort of rough idea on the increase of numbers of staff we'll need to deliver this in the future. Thank you.
I think just as a broad comment back, there's obviously, and Geraint has got his hand up, so we'll come in, but we do undertake workforce kind of forecasting and planning that informs some of the commissioning of particularly staff that we need in training, but recognising lots of our, especially work we were talking earlier around the nursing home and the care home sector and social services, that's a much broader piece that we need to be taking forward as part of the RPB agenda. But yes, all of those issues will be picked up through those forums. I don't think we've got a perfect calculation that shows what that looks like, but I think people are very minded to looking ahead and making sure we plan appropriately for that. But I'll bring Geraint in at this point, who I'm sure will give a more comprehensive answer.
Geraint. Geraint.
Apologies. I think the honest answer is we don't have the exact figures today. It is, as Nick has said, it's part of our it will be part of our planning process to try and firm some of those numbers up. At the moment, we're actually finalising some of the commissioning numbers, which will obviously help us address some of the workforce agenda. But it's part of our planning process, Louise. But I don't have an exact figure today.
So perhaps we can have an update when you've been able to do a little more analysis of that, please. Thank you. Tej.
Thank you, Chair. Again, like others, I'd like to say thank you for this plan. We have seen several iterations of this as it's come through. So thanks very much, Nick and Chris, for your hard work. I think I just want to repeat something that I've said in those other sessions, that this life's course events approach, I think, is very helpful, not just for us, but also the public and partners who are reading, who may read this plan, because it's very much easier to relate to how health services in this area are going to affect me and my family. And I've seen this this kind of life stage format in other areas, and it's worked very well. And bearing in mind that one of the things that we very much want to do is encourage people to relate to health services and understand that they have some control over their own health. I think this format very much appeals to that, because individuals can see where they fit in. I just have one specific question, please. I was really pleased to see in here that Living Well, Living Longer, we're planning to restart that. I was just wondering if we had any evaluation come through on that programme intuitively, and the kind of feedback that we had from individuals was very positive, and there was, as I remember, a demand for that programme to continue. But I'm just wondering if we have any evaluation, please.
Sarah, would you like to answer that, please?
Thank you, Chair. So the evaluation primarily relies on the CUMTAF data. There were continuing issues with completeness of the Aneurin Bevan data, and the CUMTAF data very clearly showed that there'd been good uptake from the population who we were trying to reach, and good engagement with the programme. So therefore, as an inverse care law programme, it reached the population it was trying to reach. And I think in restarting, we will take the opportunity to reflect on that evaluation, and also reflect on what we've learnt from the pandemic in terms of delivering population scale programmes. And we'll probably end up with something which is a bit of a combination, I think, between CUMTAF, which was very much GP surgery based. We were very leisure centre based. The fundamentals of the programme were the same, and I think there's something that is the combination of the best of both, that provides choice for people who may wish to go to their GP practice. But what was clear from our population was some people really valued the fact it wasn't in their GP practice, and I think it's about providing people with choice to increase access. But fundamentally, the evaluation showed it did achieve what it was setting out to achieve, the CUMTAF evaluation.
Thank you. Could I just add, thank you for that, Sarah. Obviously time has gone on, we have developed other programmes, and I think particularly the establishment and development of the integrated wellbeing networks will help with individuals being able to take control over the recommendations that they will have had through that programme. So I'm quite excited by that.
Thank you. I've got Chris, Emrys and Shelley. Chris?
Thank you, Chair, and thank you, Nicola. I endorse what's already been said. I think this is a much more accessible plan than perhaps we've had in the past, and it's really well put together and quite compelling in terms of our approach. The things I picked up, as you probably know, Nicola, with Chris, were around some of the issues I raised when we were talking about the financial allocations for this year. Were about how do we as a board measure success in implementing this plan. So it's all about the outcomes that you mentioned. But I think in doing that, one of the points I made to Chris was that and you've covered it, I think, in your presentation of this, is we didn't really make clear the co-protection element of this. I didn't think as well as we could have done, and I think that's something that as a board we'll want to keep our eye on. How well are we doing in terms of engaging our population in this life course approach? And equally, I thought there's an opportunity for us just to think through how we work with our partners in doing that and in delivering other aspects of the plan. I thought it was that part of the plan was it was descriptive and short, which is probably a good thing. But again, I just think how do we build on the good things that have happened over the last 12 months because of COVID in working with our partners to help us deliver this new annual plan. So those were my two main issues, but I thought it was an excellent approach, and I endorse what you said, that Chris has injected a lot of new life into our planning approach, which is great.
Thanks, Chris. Can I just pick up on one of those points, Chair?
Yes.
So, Chris, I think your point around greater co-production and working with the population and our partners on this is a really important point. And I think some of the discussion I've been having with Chris and other executive team members is around, it's probably an appropriate time in the next 12 months to kind of take stock at our strategy and maybe refresh and refocus. Obviously, Clinical Futures still stands strong, but it's possibly an opportunity to give it a bit of a refresh, and assuming we do that, that is a key opportunity for us to really go out and engage with the population and our other partners to help form what that could look like going forward. So I think the annual plan kind of sets the foundations really for us to go out and do that now in the next 12 months.
Yeah, I agree. Thank you.
Thank you, Nicola. Emrys?
So I just want to echo other colleagues' comments, chairs. That that's an excellent overview of the plan, and we've been very much involved in this all along till we got to the summary here today. I've just got two comments to make, really. The first comment is on the summary of the plan on page 40. It is quite clear what we're expected to achieve by April next year. I suppose my take on that is that we've just got to be, not to state the obvious, I can see we've got an outcome framework that we'll be measuring, but we also need to have a risk assurance management framework as well to link in with that, so that we as a board are clear what is or isn't being delivered as time goes on. And my last point was around the, we'll also, I know I've had some discussions already this week with medical director and the director of nursing about how we develop quality and delivery measures, system measures to reflect the changes going forward. And I think that's a key thing for us as well.
Thank you, Emrys. Shelley?
Yeah, again, I endorse everything that's been said, and I think the plan is excellent. And I'm really pleased that we're going to be looking at the outcomes measurement framework at the Planning and Strategic Change Committee. And my point was really, I suppose Nicola might have covered it, but in relation to preparing or getting the outcomes from measurement framework, I think that ought to be considered as a co-production with population and partners. Appreciate that might not be able to be done by the end of April, but it definitely needs to be part of what we go out and actually work with our other people on. And the only things I thought perhaps should have had a reference in the plan, which I couldn't see, and as you know, Nicola, I did pick these up again with Chris, was something around the socio-economic duty. I mean, there's a section on equality, but I didn't see that in the plan. And also the decarbonisation agenda that we've discussed today, because that is a big part of what we have to do over the next year and beyond. So I just wondered if perhaps consider tweaking the plan just to include some references to that. Thank you.
Thanks, Shelley. Just the socio-economic duty, yeah, I agree how important it is. Very much that plan of tackling health inequalities is kind of a key foundation for that. It is briefly referenced under the finance section when it talks about some of the value work. So we'll just have a look whether that can be brought forward at all, but it has got a reference. And I think the decarb one is a fair point. It links across our estate strategy, which has got a large focus on decarb, as you know, but I will look to see if we can make that a bit bolder in the plan.
Okay, apologies, I didn't pick it up in the finance section. Thank you.
It's on page 31, I think, if you want to check with feedback. Thank you.
Thank you. Paul?
Just to say, and I think that I would support what Pippa has said, I think in the bar about, and what Nicola has said, that removing perhaps the next model rather than clinical features can just be a futures model. And that would give the opportunity then to engage with the community and public on their thoughts, etc. Because I think we've moved on from the Grange hospital, and now that it's successfully opened up during the pandemic and all that was involved with that. And now there's another opportunity now to think, well, okay, we've got to the journey end with regard to that. Now let's look at what we want to do in terms of the future. So that's the one thing. And the second thing is, it was the 4 harms of COVID. I may have missed it, but I'm not sure whether it was referenced. Has it been referenced in there? Or have you got a page reference there that I must have missed it otherwise?
I'll check back where it's referenced. We haven't specifically pulled it out in terms of the 4 harms, the 4 boxes that we previously referenced. So I'll kind of review it back with Chris and see whether or not we think it's relevant in the early section.
Well, I think that because we use it quite a lot in terms of the committees, etc., so I think it would be useful to reference it somewhere. Yeah. I did look and see there were some spaces that we could look at, in terms of I think identifying those and utilise them, I think would be helpful. And if it isn't in, then could we just think about putting it in?
Yeah, thanks
for that. Thanks, Nicola. Thank you, Anne.
Are there any further questions or comments?
Excellent job. Well done.
Can I then just reflect everybody's views that this is a really valuable piece of work, very accessible and comprehensive. I think that as we develop the plan to implement it and the outcomes that we would wish to see, we will have to keep in mind whether or not we can afford it, because there's lots of extending this and developing that. And I think we've got to be very clear that we actually can support our aspirations effectively. I think that we also need to know what supports this plan going forward. For example, the research and development agenda in this organisation. Does ABCI's and value-based healthcare support? Do their programs support this? Because this is our key document, isn't it? So I think it's really, really good, and I think we've had some valuable suggestions. The fact that you've consulted quite widely on this with the RPB as well as the CHC has been very valuable, and I think I'd like to see within it a continuous reflection of the importance of integrated working, as has been mentioned. So well done to the teams. It's a really good job. And are we happy to adopt their 5 priorities?
Yes.
I don't know that. Yes. Are we?
Yes, we are. Yes.
Thank you very much. That brings us to the end of our public board meeting. We have a small confidential section to follow. So thank you very much indeed for the contributions today. We'll have a 5 minutes and then start the confidential side. Okay, thank you.